Hello everyone, am I visible, audible? Can you people see me? Kindly let me know if I'm clearly visible, audible. We will continue the session ahead. Can you write down something in the chat box, please? Let me open the chat. Okay, thank you. Okay, thank you. Thank you for responding. Thank you so much. So can we continue? So welcome you all for the second half of the session today. Okay, we have started epidemiology in the morning, the biggest portion of entire PSM. I guess 20% of the entire PSM is epidemiology only. It's a very big portion. So we will continue. Okay, so am I audible also? Shriniket, am I visible, audible, and you can see my screen also? Okay, can we continue now? Okay, so let's continue. Just a second. Let's continue. So let me tell you, I was teaching you the two types of the study. So I started epidemiological studies in the morning. I told you that we conduct 3 studies one by one in a sequence. The first study we conduct is descriptive studies, followed by analytic studies, followed by experimental studies. We conduct them in the sequence only. In descriptive study, we formulate the hypothesis. Okay, in analytic study, we test the hypothesis, and in experimental study, we confirm our hypothesis. So first thing, you get questions on these 3 things: the formulation of hypothesis, testing of hypothesis, and confirmation of hypothesis takes place in which study. You have to learn that, right? We have already completed descriptive study. In descriptive study, we have to learn 3 things: time, place, person. I told you what is the relevance of time, place, person to describe the disease in terms of time, place, person. Analytic also we completed. We have seen 2 types of study: case control and cohort. Okay, now it's time to continue with experimental study and finish the epidemiological studies, right? But before I teach you the various types of experimental studies, before that we will revise the analytic study. I have taught you 2 types of analytic study, right? The case control and the cohort. Have I taught you? I told you case control is a retrospective study and cohort is a prospective study. We have done the analysis. We have seen pros and cons of both of them. We will solve some questions for that, right? Now, can you read the question and tell me the answer? The ratio between incidence of disease in exposed and incidence of disease in non-exposed is known as, is it casual risk, relative risk, attributable risk, or odd ratio? What is the correct answer? Can you tell me what is the correct answer, please? Can you please tell me what is the correct answer? I'm waiting for the answer. So I'm asking the ratio of incidence of disease among exposed upon incidence of disease among non-exposed. This ratio is known as relative risk. Odd ratio is cross product. So this is the relative risk. I told you A upon A plus B whole upon C plus D. I told you this formula. So I guess everyone is right. The correct answer is the relative risk. The odd ratio is equal to 1 means what? Means the association is perfect, low, high, or does not exist. I told you for odd ratio 3 things can happen. Either is equal to 1, or it is greater than 1, or it is less than 1. I told you the meaning of all of them. So they are asking when odd ratio is equal to 1, what does it mean? The association between the 2 things is perfect, low, high, or does not exist. So of course, there is no association between them. These 2 are different random quantities. Just suppose smoking and lung cancer, they are not related to each other if odd ratio is 1. If it is more than 1, they are associated and smoking leads to lung cancer. And if it is less than 1, there is negative association and smoking protects lung cancer, But they are asking for is equal to 1, I will go with D. You all are right. The correct answer here is D. Which of the following is true for case control study? Tell me the true statement for case control study. Minimum problems of the bias. Is it true? Time consuming and expensive. Is it true? Easy to measure incidence. Is it true? Or suitable to investigate rare disease. Is it true? So what is the correct answer? I think you will have trouble here. Yes, rare disease. Absolutely right. Aditi? Absolutely right. So correct answer here is D. Let me explain you why. I forgot to tell you one thing. So see the starting point of the 2 studies. I told you how we do the case control. We start with 100 cases and 100 control. And we go in the past, we take the history. On the contrary, in cohort study, we start with 100 exposed person, that is smoker, and 100 non-exposed person, that is non-smoker. So we start our study with exposure. So in case control, we start with the disease, and in cohort, we start with the exposure. So that's why case control is a good study for rare disease. This is the starting point. Even the disease is rare, you can search the cases and start. And cohort study is good for rare exposure. So for rare disease, case control is good, and for rare exposure, risk factor, exposure or risk factor, cohort study is good. That is our starting point. Now read the question and tell me the answer. Where is the question? You read the question. Which of the following is true for case control? No, there is no minimal problem. High problem of bias, recall bias is there. It's not time consuming. It's very fast. It's not expensive. It's very cheap. Easy to measure incidence. No, we don't measure incidence. We measure the exposure. We measure incidence in cohort study. Here we measure exposure. But yes, it is suitable for rare disease. So correct among them is D. How many of you got it? Can we go ahead? The strength of association between a risk factor and a disease is measured by what? Is it absolute risk, attributable risk, relative risk, or p-value? So I told you how we measure the strength of association in case control study and cohort study. How we measure the strength of association? Here we have odd ratio, here we have relative risk. So they are asking for strength of association. I will go with relative risk. So correct answer here is C, because odd ratio is not there in the option. If it is there in the option, I will go with that also. So both are indicating the strength of association. Here also we have 3 options. Here also we have 3 options. Less than 1, equal to 1, greater than 1. Less than 1, equal to 1, greater than 1. Anyone having any trouble in understanding? What is the cross product ratio? The cross product ratio is calculated in which study? Is it cohort study, case control study, cross-sectional study, or ecological study? I'm asking. So cross product ratio is calculated in which study? What is the correct answer? Cross product ratio means A, B, C, D. We are doing the cross product, AD upon BC. So AD upon BC, this is the formula of odd ratio. So odd ratio is calculated in case control study. So correct answer here is B, and you all are right. You all are right. Very good. So correct answer here is B. Got it? Everyone say. Everyone please respond. The correct answer here is B. Okay. Okay, so let's go ahead. The numerical section I'm leaving. You will not get big questions on that. This is more important for university exam, but here it is not important for you. So we are done with descriptive analysis. We are done with analytic studies. Now it's time to start the experimental, the last studies. So let's start experimental studies. Experimental studies also known as a trial. Here we do an experiment. That's why it is known as trial. So here we confirm the hypothesis. The hypothesis is already formulated. It is already tested also, but now we want to confirm the hypothesis. Okay, so if you are an investigator, you have already conducted descriptive study, you have already conducted analytic study. Now you have to write your results of your study and details of your study and submit it to the ethics committee. If ethics committee gives you permission, then only experimental study can be conducted, otherwise cannot be conducted. So for experimental conducted, you require the permission of the ethics committee, without which we cannot conduct it. Got my point? Now imagine I have discovered a new drug, a new treatment for some disease. For example, for TB, I have discovered a new drug, and I'm challenging my drug is better than the already available drug in the market. So will you believe me and launch this drug in the market? No, you will say, ma'am, prove it. You have to prove it. So how to prove it? So we will do an experiment, which is known as randomized control trial. So in experimental study, we will do randomized control trial, RCT. RCT is a type of experimental study. So what we are doing in RCT? What basically we are doing in RCT? See what we are doing. This is RCT I'm teaching you, randomized control trial. It is a type of experimental study. See, just a second, let me show you. I don't have a diagram, I'm sorry. I forgot to put. So imagine, Hannah, I'm having 2 patients. This is my patient. So first of all, whatever patient is coming in the study, that is a voluntary, they can enter. Okay, now I will divide them in 2 groups. Especially we conducted for the cancer studies. For example, all the patients have stage 4 cancer. Stage 4 lung cancer, and their life is hardly 6 months. They are anyways going to die. It's stage 4 cancer. And in that case, I'm challenging that I have discovered a new drug that can enhance the life of these patients. So of course, everyone will participate. They have nothing to lose. So if the drug will work, their life will increase. If it is not working, anyways, they are going to die. So in this way, they will participate in my study. Okay, and we will test the drug. So here, we will divide the patient into 2 groups, the test group and control group. Test group and control group. In the test group, I will give the real drug, the new drug, which I have discovered. And I want to test whether it is working or not working, how good it is. And in the control group, we don't give the new drug, we give the placebo. We give the placebo. We want test and control to be comparable. Here also, we will see the effect and side effect. Here also, we will see the effect and side effect. And we want to compare the effects of both group and side effects of both group, so that we can conclude whether the new drug is good or not good. You got my point? But if you ask the patient that whether you want test group or control group, so of course, everyone will enter in test group. Nobody want to enter in the control group. Why the patient will take the placebo of its choice? No, patient nahi lega, patient will not take. So what to do? This is a practical problem we are facing. So what to do? So the solution is randomization. Randomize it. What do you mean by randomization? So whenever any patient enters in a study, RCT, they are entering, they want to enter, we will tell them that we will put you in one of the group. Whether we will put you in test group or else we will put you in control group. Which group we will put you, we don't know. Hannah, we don't know. We cannot tell you and we don't know. So if you want to participate, it's your choice. But whenever you will enter, we will not tell you whether you are in test group or control group. So patient never knows in which group patient is. So 50% chance the patient is in this group, 50% chance the patient is in this group. Each patient have 50% chance. So who is going to decide? The patient is not going to decide, of course. So I'm going to decide? No, I'm also not going to decide. The head of the investigator, then study is going to decide? No. Who is going to decide that which patient will go in which group? Huh? It is randomization. It is the luck. It is the lottery system, I mean. So I will use a lottery system. I will use a chit system, lottery system. So it's the luck of the patient. 50% chance every patient have fall in this group. 50% of the chance every patient have fall in this group. And this is known as randomization. Randomization means each patient have equal and known chance to fall in any group. And nobody is going to decide that. Hannah? So even the patient bribe you that please put me in the test group. Even there is a political pressure, they offer you financial bribe or whatever, you will not favor any patient. There is 50% chance. So it's always either with the help of lottery system or with the help of randomized control, randomized tables are there. The computer softwares are there. The computer will decide. Do the entries in the computer like the patient age, name, everything, and let the computer decide in which group the patient will go. So it's in nothing, no one's hand, I mean. So 50% chances there. Here we will give the new drug, the real drug. And here we will give the placebo. We will see the effect, side effect, and compare it. So daily we will give the drug to the patient. This is the patient. I will give a capsule here. I will give a capsule here. Externally, both the drugs look exactly same. But here it contains the real drug, and here it's empty. It doesn't contain anything. It contains powder. It contains placebo, nothing. But externally, both of them look exactly similar. So the patient don't know in which category, in which group they are. How many of you got it? This is known as randomization. So what is randomization? You take the patient. It's like this. Can you see? So this is your test group. This is your control group. You see improvement, no improvement, improvement, no improvement. Effect, side effect, and you just do the comparison. How many of you got it? Randomization. Via randomization, we are dividing the patients into two groups. What are the two groups? Experimental group and control group. Via randomization. So who is doing the randomization? Am I visible, audible? You people are not responding. Who is doing the randomization? Randomization is by lottery system. So randomization is the heart of RCT. Randomized control trial, we do randomization. Randomization is a procedure by which each participant is allocated either in study group or control group. And it is by lottery system. Nobody. So each patient have equal and known chance that in which category they are. Equal and known chance. They know that 50% chance I fall in this category, 50% chance I fall in this category. This is the new drug, this is the control. Maybe I go in the new drug and new drug is very effective and my life will increase. I'm having good effects. Maybe the new drug is dangerous and I will die. So it's a voluntary. So they are entering by their choice, knowing everything. It's a new drug. Nobody knows what is it. Whether it will show effect, side effect, we don't know that. And patients are coming into it by its choice, by giving their signature that they are volunteer to participate in the trial. Or whether they will go in the control group and they will be given placebo. But we will not tell them that whether you are in study group or control group till the end of the study. We will not tell them. Okay, so this is to eliminate the selection bias. Otherwise, everyone wants the selection in the test group. Nobody wants the selection in the control group. We want to eliminate this bias. That's why we are doing so that like can be compared with the like. We have two groups, one test, one control. Everything is same in them. Apart, this is given this group is given the new drug, this group is given the placebo. Otherwise, everything is same. So like can be compared with like. This is randomization. Got it? It is done either by lottery system or randomized control tables or computer algorithms are there. So it's not in my hand. Even I am the head of my study. I'm doing the study. I will not decide कि हाँ इस patient को इसमें डालो इस patient. I'm nobody to decide here. And it is decided purely by lottery system. And patient will also not decide. Nobody is going to decide. Got it? RCT is of two types, parallel and crossover. Let me show you. So have you heard sometime what happens now? There was a new drug for the breast cancer discovered. Recently it is discovered. The monoclonal antibody. You may have heard of it, Herceptin. Have you heard about Herceptin? Herceptin or trastuzumab. Trastuzumab is the monoclonal antibody, and the brand name is Herceptin. So there was a clinical trial carried out for that. So the study was supposed to be conducted for 10 years. In the 10 years, they have conducted a RCT for the new drug Herceptin for stage 4 breast cancer. Okay, these all were stage 4 cancer patients. They already have the meds. So here also we have cancer patients, here also breast cancer patient. This is test group and this is control group. So they got the new drug Herceptin and they got the placebo. Okay, they got the new drug Herceptin. Okay, externally both the drugs were same. Okay, now we got that the study was supposed to be conducted for 10 years, but in 3 or 4 years there was drastic change in the results. Here the effects were very good as compared to this group. So it was drastically visible that Herceptin is a very effective and good drug. Now the ethics come in between. So these are the patients, they also have stage 4 breast cancer, but they are eventually going to die because we are not giving them the real drug, we are giving them the placebo. So sometimes ethics comes in between. That's why we have to take the permission from the ethical committee before performing the experiments. We know that, Hannah. So you should not be emotional at that time. No, these patients are going to die, I should give the drug to them also. No, at that time, no. Because this study we are conducting for the world, it's for the benefit of the humanity, not for particular group of the patient. Okay, so here what so after 4 or 5 years only the study design was changed. The test group they were shifted into control group, and the control group patients were shifted to test group. This is crossover, so that the control group also given the benefit of the new drug. So either this is parallel design and this is crossover design. How many of you can understand parallel and crossover? What you are asking, Srinikit? Placebo. No, placebo is a drug which looks like the real drug, but it is empty. It doesn't contain anything. Imagine 2 capsules, one filled with the real drug, one is empty, and both of them externally look same. So all the patients are in front of me. So to some patient I'm giving this, and to some patient I'm giving this. I know to what patient I'm giving what, but for all the patient it looks similar externally. So they don't have any bias. Listen, all the patients are receiving the same drug. Now, then I will ask the effect and side effect, then it will be unbiased opinion. If I tell them you are taking a new drug, you are taking the new drug, these patients will say unnecessarily, they will say, yes, I'm feeling good, and they are getting placebo. If I tell them you are getting placebo, unnecessarily they will say, no, I'm having the side effects, I'm having no effects. I do not want any bias. Drugs act physiologically, but psychologically there is an impact. If you know that you are taking a good drug, and taking the drug itself you feel good before the drug acts, so it is a psychological impact. And if you know there is some drug which causes side effect, you are taking that drug, before it causes side effect you start feeling the effects, the bad effects, because psychologically you already assuming that this is going to happen. So we want to eliminate such bias. That's why we are doing so. You got it, Srinikit? How many of you got it? So this is the study we conduct, and especially we conducted in cancer patients, especially metastatic stage 4. So these patients are eventually anyways going to die. So they don't have anything to lose. So they voluntarily participate in the experimental studies. This is all regarding RCT, randomized control trial. Okay. So you don't have to go in the detail, Tanu. Just I told you this is parallel. In the parallel, the test group will remain as test till end, control will remain control till end. And here test after half of the study, test converted into control, and control converted into test after half of the study. So here both the groups are given the benefit of the new drugs. And here only one of the group will get the benefit, the test group, and control group will not be given any benefit. This is the reason parallel and crossover. So whenever the results are visible that test group is very effective, so we just interchange the group without telling the patient. We don't tell the patient that we are shifting to another group, they will run away. So just at our level we do so. For them there is a capsule, red color capsule. Now does it contain the real drug or does it a placebo? That they don't know. We know that what we are offering them. Say yes if you got it. Tanu, Sriniket, anyone having any doubt? This is randomization. Please understand. So the purpose of randomization is that each patient have an equal and known chance that they are falling in which category, and I want to eliminate selection bias. If I don't do the randomization, everyone will come in the test group, no one will come in the control group, and there is a selection bias. It's a type of bias. I do not want that. Got it? Can we go ahead? So this is the experimental study. We are done with studies, by the way. Okay, all 3 studies are done. Read the question, tell me the answer quickly. What is the purpose of randomization? Tell me. To equalize the effects of extraneous variables, thus guarding against bias, to allow interferential statistics to use to guard against the placebo effects, or to guard against the ethical problem in the location of the patient in experimental and control group. What is the correct answer? what we are doing with randomization. कर क्या रहे हैं हम randomization करके? What we are actually doing in randomization, we are equalizing the effects and guarding the bias. We are preventing the selection bias. To prevent the selection bias, we are doing randomization. In randomized control trial, RCT, what is the purpose of randomization? Is it to reduce double blinding, to decrease the follow-up period, to eliminate the selection bias, or to decrease the sample size? Why we are conducting randomized control trial? What is the purpose of randomization in RCT? In randomization, we are dividing the patient into two equal groups. We are eliminating selection bias. Selection bias is a very big bias. So correct answer here is C. Okay, so let me tell you, we are done with the studies, by the way. Now let me tell you bias and confounding factor. The last thing here. What is bias? Bias means mistakes. What do you mean by bias? Bias means mistakes. We do not. Bias means error. Error. We do not want error in our study. Now, we want the result is right. If I say smoking leads to lung cancer, I do not want any error in that. That is going to be confirmed now. This is the last study now. First we do descriptive study, then analytic study, then experimental. This is the last study. After that, my hypothesis is going to be confirmed. I do not want any error in that. So bias are the error in the studies. Hannah, how many types of bias are there? There are two types of bias: selection bias, information bias. Selection bias is further of 4 types. Hannah, and information bias is also of 4 types. So total 8 types of bias are there. Let me enumerate. Just understand the name and the meaning. So selection bias are of 4 types. One is the detection bias. Hannah, I mean, if I say all 100 lung cancer patients come on this side and 100 control come on this side. So how I confirm that these are 100 lung cancer patients? There should be some test now. I'm doing biopsy. Am I looking X-ray? I'm looking at CT scan, MRI. So there is some diagnostic technique. None of the test is 100%. I told you, no. Maybe I'm looking at the CT scan and by mistake it is showing the patient is having some lesion and it's not cancer and I'm considering it a cancer. So that is a detection bias. It is a type of selection bias. I'm doing wrong selection because of the diagnostic technique I'm using is wrong. It is not very effective. Okay, that is the first one. Second, Niemann bias. Niemann bias, here we take from where you will get the 100 lung cancer patients. No, it's very difficult to get 100 lung cancer patients. You will go to an oncology center, cancer hospital, and directly pick the 100 patients from there. There you will easily get the cancer patients. Now all type of cancer patients are there. So you will go to tertiary center, oncology center. So there only severe cases you will see. The mild cases do not take the hospital admission. So in our study, we miss usually the mild cases. We take only severe cases from the hospital. Again, it's a type of selection bias. So my sample size should be universal. Please understand. I'm going to give a verdict, whatever is the verdict, that is universal. That is valid for all. So my sample size should include mild cases also, moderate also, severe also, child also, young also, male also, female also. It should be like sample population. Got it? But here I will take only severe cases. Mild cases will be missed. Such bias is known as Niemann bias. Okay, that is the second type of bias. The third is the volunteer bias. What do you mean by volunteer bias? Okay. So sometimes what happens now, there are people who are volunteer, as I told you in experimental group. Although if I'm doing randomization, I will not tell them that whether you are in test group or in control group. So everyone have an equal chance of falling in each of the category. That's why I'm doing the randomization. Suppose I'm not doing randomization and I'm giving a choice that you just participate and tell me in which group you want to go. So everyone, the volunteers would prefer to go in the treatment group. Everyone would prefer the treatment group because everyone is concerned, especially the volunteer are more concerned about their health. So again, I'm having a selection bias. To remove it, I'm doing the randomization. Got my point? That is volunteer bias. Got it? And last is Baxonian bias. What is Baxonian bias? Baxonian bias is hospital admission bias. Bias due to hospital admission. In the hospital, usually, people are not admitted for one disease. Maybe the person is having multiple diseases and the hospital admission is due to some other disease, not for the disease under study. And you are taking 100 lung cancer patients from some hospital. Maybe the patient is admitted to the hospital with some other reason, not due to the complaint of the lung cancer. Okay, so hospital admission rate ki wajah se jo bias aayega, that is Baxonian bias. So I don't prefer you to learn the big definition. I want you to learn one part. The 4 type of selection bias I want you to learn. Detection bias is due to wrong diagnostic technique. Niemann bias is that mild cases are avoided, only severe cases are taken. Volunteer bias, volunteer want to take participation in treatment group, not in control group, and Baxonian bias is due to different hospital admission rate. Say yes. So take one word on which you get the MCQ. That's it. That's more than sufficient. Can I go ahead? Huh? The next is the information bias. It is also of 4 types. What are the 4 types of information bias? First is reporting bias. What do you mean by reporting? What do you mean by reporting? Imagine I'm having 100 cases, 100 control. So if I call them one by one and I take the history of exposure, do you smoke? Do you smoke? So they are very sincere now because they have the disease. ना चोट खाया है उन्होंने, उनको disease है. They will take you. Yes, ma'am, we were smoking and we smoked since last 10 years. I was smoking since last 10 years. I was smoking 4 packets in one day and 20 cigarettes in one day, 20 BD in one day. They will be very sincere in their history because they have the disease. And what about the control? If I call them, they don't have any disease. They're purely healthy. They will be, we smoke, we don't smoke. They will not actively participate in the conversation. They will not do the reporting very good. Got my point? So individuals who have the severe disease, they will give the complete record. And individuals who are healthy, they will not show any record. They will not do the reporting. So this type of bias, it is a human psychology. Hai na? So this is known as reporting bias. Ideally, I want these also and these also equal reporting I want. Okay. Recall bias, I already told you. Na? The person always have memory problem. Recall bias. This is basically true in case control study, not in cohort study. So recall or memory bias is always there. Okay. This bias is not there in the cases. They can recall it well. Ki, we have smoke. I have smoke. That's why I have the disease. But the control, they cannot recall it much better. They say, I don't remember. It's not, I'm not very sure. These will be the answers. Okay. So that is recall bias. Interviewer bias. I am in the interviewer. No, I am taking interview of these also, these also. So I know these are the cases, these are the control. So I will give proper time to them. And I will take a detailed history. Okay, you smoke since how many years, how many packet, how many BD, how many cigarette, how many cigar. I will take a detailed history. And here I know they don't have disease, these are control. I will say, you smoke. Okay, come next one. So like that. So ideally, I should dedicate equal time and equal questionnaire for both of them. So again, interview also, it's human psychology. We give more time to the cases and less time to the control. That should not be done. So that is interviewer bias. And last is attention bias. Attention bias occurs in cohort study. What we do in cohort study? We take the email ID and address and phone number of everyone and let them go. And we every time call them. So they know someone is watching us. Someone. So you imagine your behavior in CCTV camera and your behavior without any camera. So whenever we know someone is watching us, we behave nicely. It's a human tendency. Everyone behave nicely. So the smokers, sometimes they don't smoke. Imagine this, someone is watching me and mere upar nigrani hai. So behavior can change. And because of which the results can change. So that is known as Hawthornian bias. That is attention bias. We are giving attention to someone and the behavior change. Human behavior changes when they know that someone is watching them. Someone is observing them. So they can change their behavior. We do not want to change their behavior. I told you the smokers should smokers only. The non-smokers should non-smokers only. I will not say them you quit smoking or you start smoking. No. The natural flow we will follow. Got it? But when they know someone is watching us, they will change their behavior. They can change their behavior. Say yes, say no, say respond, people. I taught you the 8 type of bias. How many of you got it? I told you 4 types of this bias. What do we say? Selection bias. And I taught you 4 types of information bias. Why you people are not responding? You got just learn the name. Don't go in detail. 8 naam yaad karo. Learn the 8 names and one word for that. Most of them are visible from their word only. What is the problem in that? So these are various types of bias on which you get the question. But bias is not a good thing. Now I want to eliminate bias. I do not want bias in my study. So there are 2 ways. Randomization. We have already seen randomization. Randomization, we don't tell the patient that in which group you are going to fall. Whether we are going to give you a real drug or whether we are going to give you a placebo. We will not tell you, but we will give you something. There is 50% chance I will give you red capsule daily. But that red capsule is a new drug or it is a placebo. I will not tell you that. So every time the patient is taking, he will think maybe it is a test drug, maybe it is a placebo, 50% chance. Okay. So that is randomization. So that will remove the selection bias. Number 1. Number 2, blinding. Let me explain what is blinding. Let me explain. There are 3 types of blinding. There are 3 types of blinding. I will tell you single blinding, double blinding, triple blinding. See, the patient don't know that in which group they are. Here the patient is getting real drug, the new drug. And here the patient is getting the placebo. But patient don't know. Patient don't. Actually, we don't put, something on their eyes, but we don't tell them. So patient, but the one who is giving, he knows. I'm giving. You take this drug, you take this drug. So I know. I know that what I'm giving to each patient, है ना? So this is known as single blinding. Only patients are blinded. In single blinding, only subject is blinded. The subject bias is removed here, है ना? So subject don't know. We will see the effect, side effect here, effect, side effect here, unbiased. There is no psychological component in that. Okay, they don't know whether they get a real drug or they get a placebo. This is subject bias. It is minimizing, है ना? Only subjects are blinded, है ना? But investigator is not blinded, है ना? But sometime investigator, now I'm the investigator now. So when I take the history, I will give more time to this patient, है ना? Because I know this patient has given the real drug. So I will ask, no, effect, you have the effect. Maybe I think that you may feel better today. So are you feeling better? You are having some, I will give more time. And here I know that this patient has already taken the placebo. It's faltu, है ना? I'll say. So I will not give, oh, do you have any effects? Oh, it's okay, go back. So it's not should be there. I should give equal time to both of them. But it's human tendency. I cannot do that. It's human tendency. If you tell me this is the real patient and this is placebo patient, so psychologically only, Hannah, behavior wise only, I will give more time to this and I will give less time to this. But it will create a bias in my study. Ideally, I should take effect and side effect equally in both of them and then compare. So blind the investigator also. So blind the patient as well as the doctor who is taking the history. So it is known as double blinding. The subject as well as investigator both are blinded. So if I don't know which patient is what, I'm also blinded. I don't know which patient is getting what. So I will give equal time to both of them. Say yes. That is double blinding, Hannah. And what is triple blinding? Patient don't know what he is getting. The one who is giving don't know what he is getting. But the one who is doing the calculation. Now, finally, calculations are to me, Hannah. So you had given me, ma'am, effect and side effect of this group, effect and side effect of this group. So I will psychologically feel that test drug should have good effects and the placebo one will have side effects. So I will manipulate the results like that. I can do the manipulations, but I do not want to do any manipulation. So blind me also. The one who is doing the calculations, that is an analyzer. So blind statistician or analyzer also. So calculation should be unbiased. At the end of the thing, the results will be finally conclusive without any error. This is triple blinding. So in single blinding, only patients are blinded. In double blinding, along with the patient, the one who is giving the drug and taking the history is also blinded investigator. And in triple blinding, the patient, the investigator, and the analyzer is the statistician who's doing the calculations. The person is also blinded. So it will be unbiased. The best is the triple blinding. See, all three are blinded. Say yes if you got it. I tried my best to explain you. Say something. Respond. If you got, respond. If you didn't got, still respond. Say. So that is the blinding. Blinding is a way to eliminate the bias. Single, double, triple. Got it? So read the question, tell me the answer. Karthik, the head of the study knows everything. If I'm the head of a study, these all are working under me. I know everything, but I will not participate anywhere. I know everything. I know. So I know which patient is in which group. I know. And what the person is giving to each group of the patient. I know the statisticians is doing the calculation. I will allot group A, group B like that. But I know what is group A, what is group B. Apart from me, nobody else knows. So to eliminate the bias. You got your answer, Karthik? Okay, distribution, someone is knowing in the study. It is not the case that no one is knowing in the study. In the study, apart from all these three people, there is a head of the study. The head of the study, that is the in charge of the study. Whatever is the head or the in charge, that knows everything. That will say group A, group B. We will call them group A, group B, but nobody knows what is group A, what is group B. Which group is real, which is artificial. Artificial means placebo wala. That is the meaning. Okay. So to eliminate, I do not want any mistakes in my study. That's why I'm doing blinding. I will not tell the patient. I will not tell the person, the doctor who is giving the drug to the patient and who is taking history after giving the drug. I will not tell my statistician which group is which. But I know group A is what, group B is what. I know internally. I will not tell it to anyone so that they do their job with responsibility. If I tell them, they will start doing Makari. So I will not tell them. So that is the blinding. The main purpose. Can we go ahead? I guess everyone understood. So read the question. We are done with blinding. Read the question. Which of the following bias can be reduced by giving equal interview time to the cases also, control also? We are giving equal time. If you tell me this is case, this is control, I will give more time to the case or more control, less to the control. And if you tell me this is test group, this is placebo group, I will give more time to the test group and less time. Main fatafat karungi, everyone is busy, to the control group. But by giving equal time, if by blinding, we will remove which bias? Interviewer bias. Very good. Hello. Baxonian bias is a type of what? Is it selection bias, interviewer bias, information bias, or recall bias? What is Baxonian bias? I told you, Baxonian is due to different hospital admission rate. In the hospital, the person who are admitted may have multiple diseases, and you are taking the wrong patient. है ना? So it is a type of selection bias. I told you 4 type of selection bias. One of them is Bergsonian. Okay, yes, yes. What do you mean by double blinding? What do you mean by each patient received the placebo? This is the meaning. Or placebo, patient received both placebo and test drug. This is the meaning. The patient don't know which treatment they are receiving, or the patient don't know in which trial that they are in a drug trial. What is the correct answer? What is the meaning of the double blinding? Please respond. What is the meaning of the double blinding? I'm asking. Why you people don't say anything here? So patient received placebo. This is not double blinding. Patient received both drug, double treatment. No, it is not double blinding. Yes, patient don't know anything. Patient and doctor. Karthik, ideally patient and doctor both don't know anything, but it is not the option. So among the best option, it is C. I know C is single blinding, but I can say, ठीक है, at least blinding to hai na? And patient don't know they are in trial. No, no, no. Without knowing the patient, you cannot tell them, take them in any trial. Voluntary sign is required. It is the voluntary entry. It is the consent. With their consent only they can enter. But after entering, they don't know in which wing they are, in which arm they are. Is it test arm or control arm? But they know that they are in trial. It is not the thing, we do not tell them that you are in trial. Or bina bataye karenge. No, it's against ethics. You cannot take someone's life in trouble. No, you cannot do that. So with the voluntary wish, we will do that. So correct answer is C. Although it's a definition of single blinding, I agree. Okay, so that's it. Confounding, you can skip. Not important. Okay, confounding matching, we can skip. That's it. I guess we are done. Let's come on the vaccines now. You can learn few lists. I have given you the list. The diseases under international surveillance. These are the name of the 5 diseases which are under international surveillance. So if you got any case of that, you have to report to the WHO, being a doctor. Hana? So the mnemonic is PRISM. P-R-I-S-M. P stands for polio. R stands for rabies and relapsing fever. I for influenza. S for salmonellosis. And M for malaria. Malaria, Laus-borne typhus fever. Okay, Laus-borne typhus fever is also, you can PRISM L. This is the next line you can do. Okay, so please learn these diseases. That's it. Anna, can I start the next chapter, vaccine? We are done with epidemiology. Can I start the vaccine? Are you people with me? Everyone with me? The next chapter is the vaccine. So we have studied in the chapter epidemiology. I told you the tools of epidemiology, that is rate, ratio, and proportion. We started in the morning. After that, I told you the measures of mortality. I told you the 6 measures of mortality, if you remember. I told you crude death rate, specific death rate, proportional mortality rate, survival rate, case fatality rate, standardized mortality rate, the best one. I told you the death certificate, international death certificate. Not only this, I told you the measures of the morbidity also, that is incidence and prevalence. And we have seen the numericals on that. Not only this, after that, we have seen the epidemiological studies. I taught you 3 type of studies. Descriptive, analytic, experimental. Descriptive mein we have seen time, place, person. Okay. Analytic mein we have seen case control and cohort. Experimental mein we have seen RCT. There are mistakes. These are known as bias. We have seen 8 type of bias: for selection, for information. Not only this, we have seen the methods to remove the bias. 2 methods: randomization and blinding. We have seen the 3 types of blinding. That's it. Everyone say, I tried my best to explain you the things. Okay, can we go ahead? Now, the next topic is the vaccine. A little small topic, we will finish it fast. Vaccines. You frequently get questions on vaccines. Please learn, the term vaccine is coined by Louis Pasteur, but the vaccination is coined by Edward Jenner. दोनों अलग अलग हैं. Vaccine term is coined by Louis Pasteur, and vaccination term is coined by Edward Jenner. These are 2 different scientists. Okay, the first vaccine developed is smallpox in the world. The first vaccine developed is smallpox. Okay, and first vaccine, that is smallpox, developed by Edward Jenner. That's it. Please learn. So term vaccine is coined by Louis Pasteur and vaccination is coined by Edward Jenner. Both are PYQ. Please learn that. Okay, this is national immunization schedule in front of you. You have to learn this national immunization schedule. Okay, so at birth, as soon as the child is born, we give 3 vaccines: BCG, OPV, and hepatitis B ka 0 dose, 0 dose. BCG only once is given, so there is no 0 dose. It's BCG. BCG, OPV, hepatitis B. But OPV and hepatitis B ka 0 dose. Okay, at 6, 10, 14. OPV or hepatitis B ka 1, 2, 3 dose. 0 is already given at birth. Okay, 1, 2, 3 is given. And DPT ka 1, 2, 3 directly. There is no 0 of DPT. DPT is directly 1, 2, 3. Got it? DPT, hepatitis B, and OPV. Okay, OPV, you can see. So these are the 5 vaccines given at 6 week, 10 week or 14 week. Okay, at 9 month, we give measles. Along with measles, yesterday I taught you we start vitamin A along with MMR at 9 month. And I told you yesterday, if you remember, of vitamin A, total 17 lakh units is given. Every 6 months is given that. First is 1 lakh, then 2 lakh, 2 lakh, 2 lakh, 8 times. I told you yesterday. So this is vitamin A. At 24 months, yani 2 year, we give booster of DPT, booster of OPV. And at 5 year, we give DPT booster. That's it. Anna, so this is national immunization schedule. How many of you got it? So what we give at birth, 6 week, 10 week, 14 week, Anna, 6 week, 10 week, 14 week. You tell me what we give at birth, then 6 week, 10 week, 14 week. After that, 9 month, 24 month and 5 year. Okay. We will write it again. At birth, 6, 10 and 14. Week. This is 9 month. This is 2 year. This is 5 year. Can we write it once? At birth, we give BCG. There is no 1, 2, 3. Only single dose. That's it. Anna. But OPV 0. At birth, it's 0. Anna. And hepatitis B, hepatitis vaccine, that is also 0 dose. Okay. At 6, 10 and 14, it's OPV 1, 2, 3. Hepatitis 1, 2, 3 and DPT 1, 2, 3. Okay, at 9 months we give MMR, measles and vitamin A. Okay, at 2 and 5 years we give DPT booster, but at 2 year we give OPV booster also. How many of you got it? Okay, so please learn the national immunization schedule for children. Okay. Okay, so these are the things. So let me come on the types of the vaccine. There are how many types of vaccine I'm having? There are 5 type of vaccine. 5 type of vaccine. Okay. Some vaccines are live, in which live organism, the complete organism is there and it's live attenuated. In some vaccine, the organism is killed. In some vaccine, only we don't take the organism, the toxin of the organism we take. We don't take the organism, the capsule of the organism we take, and recombinant. You got my point? Imagine a bacteria. This is the capsule of the bacteria. This is the nucleus of the bacteria. Okay. Now here, if I take complete live bacteria, it will cause disease in me. So I will attenuate it. So that whenever it is injected inside me, given to me, it will not cause the disease. It is attenuated. There is no pathogenicity, but it's live. Or else I will kill it with the help of formalin or heating. I will kill it and then inject it. So live vaccine, killed vaccine. After that, we are not giving the complete bacteria, only the capsule of the bacteria. It is known as polysaccharide vaccine because capsule is made up of polysaccharide. Okay, not only this, we are not giving the bacteria, we are giving the toxin of the bacteria, the toxin secreted by the bacteria as a vaccine. So these are known as toxoid. Toxoid is the toxin of the bacteria, which is inactivated. And lastly is recombinant. How many type of vaccines we have? Tell me the types of the vaccine. There are 5 type of vaccine. What are the 5 type of vaccine? The vaccine can be live attenuated, can be killed, can be polysaccharide, can be toxoid, and can be recombinant. Tell me the examples in each category. The live attenuated vaccine, these all are live attenuated vaccine. The mnemonic is, Rome is my best place to go yet. Okay. R stands for rubella and rotavirus both. R. O stands for OPV. Okay. M stands for measles. And one more M stands for mumps. So MMR, all 3 are there. Measles, mumps, and rubella. Okay. I stands for influenza. E stands for epidemic typhus. B stands for BCG. P stands for plague. T stands for typhoid. Typhoid ka oral vaccine. And there is nothing with go, yet stand for yellow fever. So you have to say Rome is my best place to go yet. Say the full form. These all are live vaccine you can count. So it's rubella and rotavirus both. It's OPV, measles, mumps, influenza, epidemic typhus, BCG, plague, typhoid, yellow fever. If you write down the mnemonic and say it again and again, now it's easy. And these are the live. Killed one you should learn. These all are killed. Typhoid was there here also. Typhoid is 2 type of vaccine. One is live and one is killed. Cholera, plague, pertussis, OPV was here, and this is IPV. Okay, rabies, Japanese encephalitis, and HAV. Toxoid are only 3. The bacteria which secrete toxin, diphtheria toxin, tetanus toxin, and anthrax toxin, Bacillus anthrax. So इनके toxoids आते हैं. Capsular are only 2. The bacteria which have the capsule, Pneumococcus, Meningococcus, and recombinant are HBV, HPV. How many of you got it? Please learn the classification of the vaccine. You get simple question. Let me show you the question. Read the question, tell me the answer. Are you people live? Please read the question, tell me the answer. What is the correct answer? Live vaccine include all except pertussis, BCG, yellow fever, mumps. I'm saying except. Yes. So please apply the mnemonic. Rome is my best place to go yet. Huh? So BCG is coming. Of course it's coming. Yellow fever is coming. Of course it's coming. And mumps, yes, measles, mumps both are coming. Yes, but pertussis don't come here. Pertussis is a killed vaccine. Oh, I'm sorry. Pertussis is a, you can see pertussis. Yes, pertussis is a killed vaccine. You can see it's a killed vaccine. Okay. Typhoid is both, Karthik. Two types of typhoid vaccines are available. Maybe you will read this in detail in microbiology. Two type. Oral one is the live and injectable one is the killed. Like polio also. Polio is also coming both ways. Now OPV, IPV. Typhoid is also coming both ways. Okay, so many vaccines are both. Two type of vaccines are there. So this is the correct answer here. The next question. All of the following are killed vaccine except, which is not a killed vaccine. Salk polio, Japanese encephalitis, rabies, or yellow fever. Easy one. Can you please tell me the answer? Yes. So I told you Rome is my best place to go yet. Yet ka jo Y hai, that's yellow fever. Yellow fever is a live vaccine. Rest all are killed. Okay. So in this way, you get simple questions on the vaccines. Okay. Okay. Just a second. Delayed vaccine you can leave. Yeah. The next is the cold chain. What is cold chain? Let me explain what is cold chain. Okay. So all the vaccines should be stored at 2 to 8 degrees Celsius. All the vaccines except OPV. OPV should be stored at minus 20 degrees Celsius, not 2 to 8. 2 to 8 is the temperature of the fridge. Minus 20 is the temperature of freezer. There is a difference between fridge and freezer. You know, so we all have fridge now. This is fridge and there is a freezer, the uppermost compartment. So here the temperature is 2 to 8, but here temperature is a negative, less than 0. So I want OPV to be stored here and rest all vaccines to be stored here. So OPV to be stored, where it has to be stored? At minus 20. So I'm talking about OPV. I'm talking about OPV. OPV is minus 20 and rest all vaccines is at 2 to 8, as I told you. So this is the point where the vaccines are manufactured. This is the manufacture unit. So from manufacture unit, the first vaccines will go at district hospital. Then they are supplied to CHC. Then they are supplied to PHC. Okay. Then they are supplied to sub-center and they are supplied to the camp, village health guide, and they are supplied to the finally camp. This is the camp in the village. So everywhere the temperature has to be maintained. Everywhere. During transport also you have to maintain the temperature. If the temperature is not maintained during the transport, it will become ineffective. So this is known as cold chain. We have to maintain the cold chain from the point of manufacture till the point of the delivery. This is the delivery to the child. We are delivering the vaccine to the child. And this is the manufacture. So from the point of the manufacture till delivery, we have to maintain the cold chain. By maintaining cold chain, I mean all the vaccines should be stored at 2 to 8 and the OPV should be stored at minus 20. So here we have various instruments, which like fridge, freezer, we have. And during transport also, we require the vehicle, which is having the fridge and freezer inside that. Got it? This is known as cold chain. How many of you got it? You got it? What is cold chain? So this is the manufacture unit. From manufacture unit, it is PHC, then health center, then immunization venue, and finally the patient. Okay, so this is the complete chain you can see. So at district hospital, first thing is district hospital. We have walk-in rooms. Have the image? These are walk-in rooms. The complete room is fridge. Room ka room hi fridge hai. It is known as walk-in cold rooms. WCR, walk-in cold rooms. Have you seen the room? Complete room is fridge. And the temperature 2 to 8 degrees is maintained. Right, you got it. After that, we have PHC and CHC. At PHC and CHC, there is ILR. What is ILR? Let me show you. ILR is ice-lined refrigerator. It's like this. Have you seen at PHC and CHC? We don't have rooms. We have ice-lined refrigerator. It is known as ILR at PHC as well as CHC. From inside, it's like this. Okay, so there is a freezer also. There is a fridge also. Ice-lined refrigerator. Okay, and after that, at the sub-center, we have nothing. So we carry the vaccine to the subcenter on the day of immunization only. We don't store the vaccine at subcenter. And we carry in a day carrier. What is day carrier? These boxes are cold boxes or day carrier. Can you see the cold boxes? So apart, so in this cold boxes, we will keep the ice packs. Can you see this is an ice pack? So from the four side, we are keeping an ice pack, and in the center, we will keep the vaccine. Okay. So you can see this is a day carrier. This is a vaccine vial carrier. These are the cold boxes. Say yes, cold box, day carrier. So there is an ice pack which we keep inside. How many of you got it? So this is how we store the vaccine. This is complete cold chain. So at every level, you have to check the temperature twice in a day with the help of a thermometer, dial thermometer. This is dial thermometer. This is dial thermometer. You have to check the temperature. You have to check the temperature here in the cold boxes, in the ILR, in WCR. So any healthcare provider like the ASHA, Anganwadi worker, or male health worker, female health worker, they should check the temperature twice in a day. And temperature should be maintained. It should be measured twice a day with the help of dial thermometer. Okay, so that is the thing. That is the thing. So all the vaccines at 2 to 8 degree, except OPV, it should be -20 to -40. Vitamin A should be stored at room temperature only. And there is maximum chances of failure at subcenter and the village because there is no storage there. So maximum chances of the complete cold chain. Tell me the cold chain. So from the point of manufacture, first it go to district hospital, then CHC, then PHC, then subcenter, and then village, and then the camp and the village. This is cold chain. So what instruments we have? This is the manufacturer. Here we have walk-in cold rooms. Here also we have walk-in cold rooms. Here we have ice-lined refrigerator. Here also we have ice-lined refrigerator. Here we have nothing. That's why we carry in a container which is known as vaccine box. I have shown you the cold boxes, the vaccine carrier, the vaccine boxes are there. We carry on the day of immunization. So maximum chances of failure is here. Maximum chances of failure before the delivery to the child. Maximum chances of failure. Yes, these images you should learn. Now, dial thermometer can come in your exam. You can see it's the dial thermometer. You can see the unit is degrees Celsius. In the degree Celsius, it is measuring the temperature. You can see, they can ask you what is the image for. It is a day carrier. You can see, this is a day carrier. You can see this is ILR. Okay, you can see this is walk-in room. We should understand at least. Anything can be asked. I cannot guarantee. So we are done with the cold chain. Please read the question. Tell me the answer. Temperature in ILR at PHC is recorded by using which thermometer? Carta thermometer, sling thermometer, dial thermometer, or anemometer? Yes, so of course it is measured via dial thermometer. Conventionally it is measured by dial thermometer. I told you ice packs kya hai. That's it. Okay. What about OPV? I told you OPV, na? What about OPV? What is the temperature we require for OPV? What is the temperature we require for OPV? -20 to -40. You can imagine -20 to -40. Very difficult to maintain. एक जगह maintain हो भी गया. For example, at district hospital we are maintaining, but maybe at PHC, at CHC there is power cutoff. Power cutoff is very common in villages. For hours and hours, electricity is not there. If electricity is not there, how the ILR will work? ILR is not working. Power cutoff is there, or due to any reason, the temperature is not maintained and it will become ineffective. So what is the sense? What is the sense? You are doing a big chain, like from the point of manufacture, district hospital, then PHC, then CHC, then PHC, then subcenter, and finally the village. And finally the child. The mouth of the child, the 2 drops, do boon zindagi ki is the logo. I'm talking about OPV. So OPV is manufactured here at -20 to -40. Then it is transferred here, 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 and finally to the child. So when you are giving 2 drops to the child, how sure you are that complete cold chain is maintained? Whatever 2 drops you are giving in the mouth of the child here, they are effective only if the cold chain is maintained everywhere. By maintaining of cold chain, I mean the temperature maintained -20 to -40, which is very difficult to maintain. You can imagine -20 to -20, such a low temperature. Imagine if there is a failure here, failure here, failure here, maximum chances of failure here, here, any point, or failure during the transport. Anytime the cold chain can be broken. By breaking of the cold chain, I mean the temperature is not maintained. So you are giving 2 drops to the child, but it's ineffective. There is no use of giving. It's totally wastage of the complete manpower, complete energy, complete money, complete time, wastage of everything. You have wasted everything. Technically, you have wasted. है ना, because whatever 2 drops you are giving, that's ineffective. You have not maintained the cold change. So there should be a way now to judge whether whatever we are giving in the mouth of the child, it's effective or not effective. What is the way? Is there is a way? I'm asking, is there is a way? Yes, there is a way. It is known as VVM. It is known as VVM. No, it's possible, Sriniket, not in Antarctica. Everywhere in the country, we make it possible. Our government is great, na? Indian government is great. We make it possible. Hai. So it is known as VVM, Vaccine Vial Monitor. What are these VVM? These are stickers, hai, that contain a chemical which is temperature sensitive. Hai. So can you see the stickers on the vials? Please see the stickers on the vial. See, hai, you can see the stickers. Can you see the stickers? In these stickers, these are the labels that contain the temperature sensitive chemical. So in all the stickers, you can see there is a circle which is blue color. Circle is always blue. Circle is always blue. It doesn't contain the temperature sensitive chemical. Inside the circle, there is a square which contains the temperature sensitive chemical. So it should be white. If the temperature is -20 to -40, you are maintaining everywhere from first point till last point, till reaching the mouth of the child, it should be still white. Means the complete cold chain is maintained, and whatever you are giving in the mouth of the child, that's 100% effective. You become double sure, and happily you can give it to the child. You can deliver it to the child. But if at any point the temperature is not maintained, there is a break, you don't know whether at PSC, CSC, district hospital, subcenter, kahin pe bhi, and during the transport, at anywhere the cold chain is not maintained, there is a breach, hai na? So it will become the square start becoming darker. So you can see it's not white, it's light blue. Now here it's white, here it become light blue color. You can see it's light blue. It's more than white, but less than the outer circle. It's known as grade 2. Hai na? If still the cold chain is not maintained for a bigger time, there is a big breach. Hai na? Here only for 1 hour or 2 hours it is not maintained. Here maybe for 24 hours it is not maintained. Hai na? So the outer and inner become same color. Outer and inner become same color. Outer circle and inner square become same color. And if it is not maintained for many days, hai na, the temperature is not maintained. So inner square become darker than the outer circle. है ना? So यहाँ पे white है, यहाँ पे light blue है, यहाँ पे blue है, यहाँ पे dark blue है. Till what stage you should use in a child? Ideally, you say कि ma'am only stage 1 is used, grade 1, grade 2, 3, 4 should be discarded because they are ineffective. But in a country like India, where we have limited funds, limited resources, we cannot do such a wastage. We cannot afford that actually. So till stage 2 we afford. है ना? Stage 2 is not 100% effective, but partially effective. So we will take a chance. And it's at least partially effective, na? So we will give grade 1 and grade 2, but grade 3 and 4 we discard. Say yes, say no, say something. So this is the outer circle, inner square. The inner square is having heat sensitive, temperature sensitive material. Outer circle is always blue and inner is white. Inner is white. Got my point? So this is the thing. So outer circle and inner square. है ना? This is always blue, 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 blue. Here it is white, then it become light blue, then it becomes same blue, and then it becomes dark blue. Dark blue. Say yes. है ना? So this is known as grade 1, 2, 3, 4. WHO says up to grade 2 we can use. After grade 2 we have to discard. So these can be used and these have to be discarded. है ना? So at the time you are delivering it in the mouth of the child, please check the label. Without that you cannot deliver it directly. 2 बूंद पिलाने से पहले label check करो. पिला रहे हो तो वो ठीक है कि नहीं है. And it's effective or not effective. So can I say it's a method of checking the potency? It's a checking the potency. It's a marker of potency of the vial of the vaccine, of course. है ना? So I'm sorry, it is known as VVM, Vaccine Vial Monitor. Got it? Read the question, tell me the answer. See the 4 images in front of you. It's the image-based question. Which of the following OPV vials are usable? Only 1, 1 and 2, 1, 2, 3, or 3, 4? I'm asking you. Look at the 4 images. Look at the square inside that. Karthik, absolutely right. Elizabeth, right. Mahima, right. Aditi, Leah, Vasudha. Right? What about others? Please everyone reply. I told you, na, up to 1 and 2 we can use. 3 and 4 has to be discarded. So till it is lighter than the outer circle, you use it. Once it becomes equal or darker, you just discard it. Anna, we do not teach all these things to the person who are like Asha, Anganwadi. They are not very educated person. So what we teach them, simple language में क्या बोलेंगे उनको कि अंदर का square, if the inner square is lighter than outer circle, you use it. If it becomes same or darker, discard it. This is simply what we teach them. Okay, because many times it is given by them only, no? So this is the thing. Okay, so this is the correct answer. We are done. Okay, none of the live vaccine should be given in pregnancy. None of the live vaccines are live attenuated, no? Live attenuated. Although they are attenuated, what do you mean by attenuation? They are weaker. They are the live organism, but they make weaker so that they do not cause disease in human. Imagine you are giving a live polio virus, but it is attenuated. It will not cause polio in me. I am an adult. But you know, there is a pregnant lady, imagine, inside which fetus is present. So the attenuated organism can cause disease in fetus. Fetus mein immunity is not very good, na? So sometimes, so all the live attenuated vaccines are contraindicated in pregnancy except yellow fever. Yellow fever can be given. If any vaccine is frozen, all the vaccines where you have to keep, this is fridge, and above fridge we have freezer. All vaccines should be kept here, है ना, at 2 to 8, है ना, in the gate of the fridge, है ना, and in the freezer only OPV has to be kept, -20 to -40. Got my point? If any vaccine accidentally you keep here, any other vaccine, it will get frozen. So what you will do now? Accidentally you put any other vaccine in the freezer and it get frozen. It become ice, it become frozen, I mean, है ना. So what usually the healthcare providers they do, they just thaw it, है ना, उसको वापस liquid बना के they inject. No, discard it. Once frozen, it has to be discarded. You cannot again thaw and reuse. Once frozen, accidentally by mistake discarded, it's of no use. It's of no use. Okay, got it. Live and kill vaccine can be given together. Before vaccine, don't apply any spirit. Don't apply any spirit. Give it directly. Because what is spirit? It's alcohol. Alcohol will kill the organism. If it's a live attenuated vaccine, it will kill the organism. So don't use any spirit. Anna? So please learn these general rules. Got it? Say yes. So please read the question and tell me the answer. All of the following live vaccines are contraindicated in pregnancy except. Which live vaccine is not contraindicated in pregnancy? Yellow fever, BCG, rubella, or OPV? What is the correct answer? So I told you all the live vaccines are contraindicated except yellow fever. So read, yes, learn, it's yellow fever. Now let me tell you 4 and 5 individual vaccines and pack this chapter. Okay, individual vaccines we will see the first vaccine is BCG. Let me give you a few details of BCG. Okay, tell me the strain of BCG. You have to learn the strain of all vaccines. Hannah, I will give you a table in the end. So strain of BCG is Danish 1331. Please learn Danish 1331. That is the strain, that is universal. Throughout the world, we use the same strain. What is the diluent we use? It's normal saline. Hannah, what do you mean by diluent? Listen, BCG is in the form of powder. You cannot inject a powder. First, you have to liquefy it. So in which liquid you will mix the powder? We will mix it with normal saline, which is supplied with this only. So you get two things, the powder and the normal saline. Mix the two. Take the normal saline in a syringe and put it in this vial and shake it so that powder get dissolved in the normal saline. This is known as diluent. You have created the diluent. Now you give intradermal injection. Intradermal. The route is intradermal. You give in left upper arm. Always conventional. BCG is given in left upper arm, and you can see a mark also. You can see you may be having a mark over here. So left upper arm. Okay. So first there is ulceration, then suppuration, osteomyelitis. Sometimes happens. Okay, and dissemination will be rare of the rarest. Otherwise, there is an ulcer, and there is a mark of that. Okay. So these are the important points. Got it? What is the diluent? It's normal saline. Okay, this is BCG. Read the question, tell me the answer. The strain of which of the following is used for BCG at commercial level in the world? Is it, this is the full form of BCG. Bacilli, Colmiti, Gurin. Is it Tween 80, Danish 1331 or PPD, RT? So of course, it's Danish 1331. Please learn all the strains at one place. The next is DPT. BCG ho gaya. Next is DPT. DPT is a triple vaccine. It contains 3. D, diphtheria, P, pertussis, T, toxoid. So in the D, P, and T, I told you these two are toxoid. They contain the toxin. This is a toxoid, this is a toxoid, and this is a killed bacteria. This is not toxoid. I told you 5 types of vaccine at the beginning only today. I told you there are live vaccine in which the live organism is there. I told you there are killed vaccine in which the killed organism is there. I told you not the complete vaccine, only capsule is there, the polysaccharide one. And I told you the next is the toxoid, in which we don't inject the bacteria, we inject the toxin of the bacteria. So these two are toxoid. See the examples there, diphtheria and tetanus. But pertussis is a killed vaccine. So these two are toxoid and pertussis is a killed vaccine. Got it? So these two are toxoid, D and T. But pertussis is a killed vaccine. We require adjuvant, that is aluminium hydroxide or phosphate. We require a preservative, that is thiomersal. The route is intramuscular and that too on thigh, not on arm. We give it on left we give it on lateral aspect of the thigh, middle part of the anterolateral thigh. It's always intramuscular. It's always intramuscular. Only one adverse reaction, that is rare of the rarest, that is neurological. Neurological can happen. Okay, that is about DPT. Okay, read the question, tell me the answer. Not true for pertussis vaccine. Neurological complications are common with whole vaccine. Efficacy is 90%. Administered as triple vaccine, the vaccine is live attenuated vaccine, which is wrong. Which statement is wrong for pertussis? DPT के P के लिए क्या wrong है? It is given as triple vaccine, it's right. है ना? Triple तो देते ही हैं DPT. Efficacy is also very good. है ना? And neurological complications are also common. But this is not live. This is killed vaccine. I told you this one is killed. है ना? D and T are toxic, but T is killed. है ना? So next is measles. We give measles in the form of the MMR. Measles. Learn the strain and Mostyn Jagrib. What was the strain of BCG? Danish 1331. Don't try to mug it up. Have a look. है ना? Measles का strain क्या है? And Mostyn Jagrib. I will give you a table in the end. जिसमें सारी strains at one place you have to learn. It is also in the form of the powder. I forgot to put the image. It is also powder like BCG. But you have to dissolve it in distilled water, not in normal saline. Okay, so tell me the diluent of BCG and tell me the diluent of measles. Both are powder. So you have to dissolve this in normal saline and this in distilled water. How you are going to learn that? You get questions on both. You get questions on both. So make some mnemonic, है ना? BCG से saline याद आना चाहिए, BS, और measles से water याद आना चाहिए, है ना? You learn like that. Listen, M measles or water is W. So for measles, it's water. Now you will not forget. For measles, it's water. Water means distilled water. So we dissolve the measles ka powder in distilled water. You can learn M or M ka ulta is W. W is water. You can learn like that. And here BCG, we dissolve in. We write B like this, na B. So B ko ulta kar do to S ban jayega. है ना? It's saline. It's a way of learning. So B se ban jayega S. You learn like that. है ना? I hope you are getting. So I'm just taking you the trick so that you don't confuse in the exam. Okay, Ji? है ना? So this is how you have to learn. Okay, so learn the diluent. Both are powders, but in which thing we are mixing? Okay, learn here we require a stabilizer. The stabilizer is sorbitol. The route is subcutaneous and we give it in upper arm. Right upper arm, not left. In the left, we give BCG. In the right, we give MMR. Complication is toxic shock syndrome. Learn main complications. So whatever questions you get, I have already enumerated here. You have to just learn that. So toxic shock syndrome is a adverse effect of which vaccine? Answer is measles. Answer is measles. Vitamin A I have already taken. Hana, we give it with spoon. The capacity of the spoon is 2 ml. Hana, 1 ml contain 1 lakh. I told you how many total doses we give. Total we give 9 doses. Hana, 8 plus 1, 9. The first dose we give at 9 month, and after that, 18 month, 24 month, 30 month, 36 month, 42, 48, 54 and 60. So here we give 1 lakh. है ना? And here every time we give 2 lakhs. So if you count 2, 4, 6, 8, 10, 12, 14, 16 plus 1, 17. Total 17 lakh. Yes, yesterday I taught you the prevention of the prophylaxis of vitamin A. Okay, the first is given at 9 months. It's a PYQ. Okay, ji. Last is polio, OPV, IPV. I will pack them. Hana? Then we will come on another chapter. Are you people still alive? How many of you are alive? I guess people are still there. Can we continue? So next is OPV and IPV. We have 2 types of vaccines available for this thing. Polio. Have you heard about polio vaccine? The 2 vaccines. Please understand. OPV is oral polio vaccine. 2 boond zindagi ke. And IPV is injectable. This is given in the form of the injection. So we have OPV, we have IPV. We have 2 types of vaccine, OPV and IPV. Okay, instead of learning the table here, you get many questions on that. Let me tell you here. Let me tell you normal polio diagram. Can you see normal polio virus? How does it enter? So normal polio virus enter through contaminated food and water. This is normal polio virus go inside the human mouth via contaminated food and water. Polio virus, not vaccine. It go in the esophagus, it go in the stomach, it go in the intestine. From the intestine, it get absorbed and it reaches the lymphatics, mesenteric lymphatics pair patches. And now it remains in the lymphatics. From the lymphatics, it goes in the blood. From the blood, it goes to the spinal cord and destroy anterior horn of the spinal cord. Person have paralysis, flaccid paralysis. That is paralysis in the polio. This is how polio causes paralysis. How many of you understand this? You got it? This is how polio causes paralysis. Now I will teach you two vaccines in the same diagram. Let me erase it. OPV and IPV. What I am going to teach you? The two vaccines. OPV is given orally and IPV is given in the blood. Let me tell you. OPV, oral polio vaccine. IPV, injectable. This is given orally, 2 drops, है ना? And this is given injectable, intramuscular या फिर subcutaneous, injectable. ठीक है? Oral one is the live vaccine, and the injectable one is killed. Okay, this one is live attenuated. You see the classification. Rome is my best place yet to go. So Rome का जो O है, ROME, O is OPV. Okay, so it is a live attenuated vaccine, and this is a killed one. This is discovered by Sabin, a scientist known as Sabin. That's why known as Sabin vaccine. This is discovered by a scientist known as Salk. That's why known as Salk vaccine. How to learn? Sabin and Salk में मुझे तो confusion होता है. I get confused. तो मैंने कैसे learn किया है? Killed is KL और Salk में LK. KL LK है ना? तो जो Salk है वो killed है. I learn like that. So obviously Sabin is live. है ना? Sabin is live. Say yes. Say yes, this is a way to learn. So Salk is LK. उससे मुझे killed याद आ जाता है. Salk, SALK. LK is KL. That is killed. This is how I learn. Okay. So please learn the basics. Okay. So in this diagram, I will. So which one is better according to you? OPV or IPV? I'm asking. General question. If you want to give vaccine, one vaccine to a child, which you will prefer? You will prefer oral or IPV? Tell me a reason also. Tell me, common sense, use your common sense. Now, which you will give to the child, oral or injectable? You want to give a Sabin one or Salk one? You want to give oral, oral. Tanu is saying oral. Leah is also saying oral. Aditi is also saying oral. Mahima is also, Elizabeth is saying injectable. So, Elizabeth, why injectable, and others all, why oral? Write the reason. Tukka nahi marna hai. Say your reason, whatever you think. It's okay, whatever. How, jitna bhi jo bhi soch rahe ho tum, bas write it. Why? It is cheaper. That's why. Doxycycline. That's why you prefer. It's painless. Very good, Pallav. So Pallav is saying sensibly that it's painless. I mean, oral route is easy, na? To my kid also, I will also prefer oral. Hana? The kid will also cry in the injectable. Nobody likes the injection. No kid. किसी भी बच्चे को injection पसंद नहीं है. Parents also don't like someone is giving injection to their child. है ना? So oral is better. Route wise, it's better. So I will tell you the advantages and disadvantages of oral. The advantages of oral are disadvantages of injectable, and the disadvantages of oral are advantages. Ulta pulta hai. है ना? And you yourself decide which is better. You will decide. Let me explain both. Give me 2 minutes. Let me start with oral. So oral, you are giving 2 booons zindagi ke. Oh no, you are giving via mouth. You can see I have drawn 2 drops. है ना? So oral will go inside, inside, inside like this. It will go in the stomach. It will go in the intestine. Like natural virus only, it will go in the lymphatics. Like natural virus only, it will go in the blood. Say yes, like natural virus only. This is OPV. I'm talking about OPV. Say yes, Hannah. Let me enumerate the advantages. Everyone here. Number 1, it's easy to administer. Hannah, the route is very easy. Orally, child aram se say and give the 2 drops. Okay, easy to administer. It's cheap also. Hannah, it's cheap to manufacture, and it's easy to manufacture also. Hannah, easy to manufacture. It's cheap and easy to give. Easy to administer also, easy to manufacture also. You will say, man, everything is good till now. All are advantages. Okay, I agree. Let me tell you a few more advantages. Once it will go in the intestine, in the intestine, IgA antibodies are formed. You know, in the intestinal secretion, IgA antibodies are formed. This is known as local immunity. So in the intestine, we have local immunity, and when it will go in the blood, all other antibodies are also formed. IgG, IgM, IgD, Ig, all of them are formed. This is known as systemic immunity. So I mean to say it's giving double immunity. One in the intestine, one in the blood. You say, it's good. We are having double immunity. In future, if real virus is entering via oral route, so intestine में उसको निपटा देंगे. In the intestine only we have antibody and we will destroy the real virus. By chance, the real virus is entering in the blood, we have double immunity there. So it's double immunity. It's also good. Local also, systemic also. I feel good. Okay, I agree. It is having double immunity. It's good. Hannah, this is also an advantage. Okay. Okay. So let's go ahead. Listen. Okay. Listen. Now, where you are giving oral via mouth, na? So it is going in the mouth, esophagus, stomach, intestine. Will it be excreted in feces? Yes, a little bit. It will come in the feces from the intestine. Rest, it will get absorbed in the lymphatics and the blood. So it is excreted in the feces. It is excreted in the feces. Okay, it's right. So you are giving it to the child. Now these feces will contaminate the food and water. It will contaminate the food and water, and it can go in the mouth of another child who is not vaccinated. Via contaminated food and water, it can go to other child. So imagine I'm organizing a camp in a village, Hannah, and I'm doing the publicity that everyone, whosoever is having less than 5-year child at their home, they should bring their children in the camp. We will give them vaccine. So out of the 100 child in a village, only 40 are coming in my camp. Out of, I'm doing all the marketing publicity, I'm asking everyone, requesting to bring their child. We are announcing on the radio, TV, newspaper, but still only 40 childs are coming, 60 are not coming. It's okay. You give 2 drops to those 40. Those 40 will pass the virus in their feces after getting it. The day they pass the feces, the next day they passes the feces. And it will contaminate the food and water, and via contaminated food and water, the 60 who are non-vaccinated, there is a chance that we can reach the vaccine. So this is the only scenario where we want contamination of food and water is a good thing. You got my point? So we can vaccinate the non-vaccinated also by giving vaccine to these only. Anna, it will increase the herd immunity. So is it useful in herd immunity? Yes, it increases the herd immunity. हम दे आधों को रहे हैं, बचे हुए आधे खुद ही वैक्सीनेट हो जाएंगे, है ना? Through contaminated food and water. Contamination of food and water is common in villages, overcrowding, poor hygiene. Got it? Say yes if you got it. So this is also useful, है ना? So herd immunity के लिए भी अच्छा है. And the non-vaccinated one also getting vaccine. So is it good for epidemics? Yes, in epidemics also it's useful. For herd immunity, it's useful. You are saying, ma'am, everything is good, good, good. Why you are saying it's not good? So let me enumerate the uses. It's easy to administer. It's easy to manufacture. It's very cheap. It gives double immunity, the local also, the systemic also. It's useful in epidemic. It's useful in herd immunity. And the non-vaccinated one will also get vaccine through contaminated food and water. So what is the problem? 2 problems are there. Let me enumerate the 2 side effects. I mean, the 2 disadvantages. It is live. Have I told you? Have I told you OPV is live, although attenuated, but it's live. Hana? So you are giving a live virus. So you'll say, ma'am, it's okay, na? It's attenuated. After blood, it will not go in the spinal cord like natural virus. Natural virus after blood going into the spinal cord because it is pathogenic. But here, whatever virus you are giving in OPV, it's live, like natural only. But it's attenuated, it's very weak. It will not go in the neural system and cause the disease. It's non-pathogenic. But sometimes think if attenuation is not proper. Kya hoga aage? It will follow the course of the natural virus. It will follow the course of the natural virus. It will go in the spinal cord and causes the paralysis. So paralysis is known as vaccine-associated paralytic polio, VAPP. Imagine, हम vaccine क्यों लगाते हैं? Why we give vaccine polio to the children? So that they don't have polio. Imagine a child who has given the vaccine or vaccine की वजह से polio, the parents will kill you. Literally, it's permanent paralysis. If you give any child a paralysis, the parents will be mad like anything. Imagine a couple who is very educated, very aware, and they are regularly giving vaccine to their child, and they are giving OPV to their child to prevent the polio. And because of the vaccine, the polio occurs to their child. What will happen? Imagine. But there is always a chance. There is always a chance. This is known as vaccine-associated paralytic polio. How many of you got it? No. All the chances is 1 in million. 1 in 1 million. So in India, only 3 or 4 cases are found till date. But they are the children of someone. Okay, so they will be permanent paralytic. There is no treatment available. Once paralysis occurs, it's forever. Got it? So this is the one disadvantage. VAPP is a risk. Always a risk. Number 1. Okay, number 1. Number 2, the storage. Aditi, there is storage here. Na? We have issues of storage here. Because temperature, I told you, -20 to -40, which is very difficult to maintain. Now, VVM, we have to use the VVM and a vaccine vial monitor. So storage is very stringent and difficult. So 2 disadvantage is VAPP and storage. I am done. Say yes. Everyone say yes. Got it? So let me teach you IPV now. IPV is given directly in the blood. We don't give orally. Of course, it's IPV, injectable. This is the Salk one. This is the killed one. Salk se yaad aa jata hai KLLK. This is the killed one. It will directly go in the blood, so it will give only systemic immunity. It will not give local immunity. It's painful. So route is not easy. It's painful. It's difficult to manufacture also, and it's costly also. So all the disadvantages are advantages are disadvantage here. That was easy to administer, it's painful. That was easy to manufacture, this is difficult. That was cheap, this is costly. Hana, that was giving double immunity. This is giving only systemic immunity, no local immunity. It is not passed in feces, so not used in herd immunity, not useful in epidemic. है ना, all are disadvantage. लेकिन advantage सिर्फ दो हैं. वहां के जो disadvantage थे, there is no chance of VAPP because it is a killed virus. Never, 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 not even a single case of VAPP. So it's safe. Number one, it's safe for immunocompromised people also. है ना, immunocompromised people maybe you can give. Number one. And number two, storage is okay. Storage is 2 to 8 degree. It's not minus 20. So that is the only two good things here. So what you will prefer now? OPV or IPV? Both have its own pros and cons. Now please read it. You will understand everything. OPV, IPV. All people are with me? Can you help me in reading this, please? OPV is Sabin, IPV is SARC. है ना? So this is live, this is killed. This is given orally, this is given injectable. Okay? Here double immunity. Humoral and intestinal. Here only systemic, that is humoral, no intestinal. Right? Here it is effective in epidemic. It is not effective in epidemic. Okay, here it gives herd immunity also, it don't give herd immunity. Manufacture is easy, manufacture is difficult. This one is cheap, this one is extensive. Here storage is sub-zero. Sub-zero means minus 20. And here less stringent. Shelf life is short, it's long. Here VAPP is always a chance, although 1 in 2 million. 1 in 2.7 million. Rare of the rarest. But here there is zero chance. Got it? How many of you got it? How many of you got it? Okay. Okay. So what you are asking, Aditi, some nurses take some dropper and go home to home, give drops to the baby. Does it affect outside temperature is hot? So those nurses who are taking, now you are talking about pulse polio immunization. In pulse polio immunization, we go door to door. So government is doing so much. If the patients, I mean the child are not coming to the camp, we will go door to door delivery we give. But we always carry them in vaccine boxes. Those nurses have vaccine boxes having the ice packs inside that. They take it out, give the 2 drops and put it back. So temperature should be maintained. And it's a right. If you are educated, you can ask the nurse to show the VVM. If the VVM inside square is white color or light blue color, then only it should be administered. Okay, so they know this rule and they should check it. And if any vial is this thing, like it's already ineffective, it should be discarded. Yes, they are carrying a box like ice. Absolutely right. Can we go ahead? Can we go ahead? So the same thing is written in front of you. Okay, so read the question, tell me the answer. SARC vaccine is what? Is it live, attenuated, killed or toxoid? SARC, LK. LK is KL. Hana, you will not forget. The correct answer is C, you all know. Can we go ahead? Huh? So that's all about it. The important, this was the table I'm talking about. Please read all the strains at one place. So BCG ka strain, I already told you, Danish 1331. Okay, OPV is not important. Measles ka strain, I already told you, and Boston Zagreb. Mumps का strain Jarrell Lin. Rubella का strain RA27/3. Yellow fever का strain 17D. Varicella zoster का strain Oka. है ना? Japanese encephalitis का Nakayama strain. Okay, so read the main strain. Typhoid का strain type P TY21A. So these are the important strain on which PYQs are there in your exam. I would like to stop here. Okay. Okay, can we go ahead? Mission Andradhanush I will cover. They are in the national health programs. So let's finish it. Just a second. Let me start the next session. Next chapter, I mean. Can I start the next chapter? We are done with epidemiology. Are you people with me? Enjoying? Learning? So just a second. Let me open another PPT. We are done with epidemiology. So let's start another unit now. Preventive obstetrics, pediatrics, and geriatrics. Can we start? Can we start just in 5 minutes? Can you give me a just 5 minutes break and we can start after that? Continuously. So I will start with this chapter and non-stop we will finish this chapter in one go. Okay. So just in 5 minutes we will be back. Okay. So I'm not ending anything, just switching off the camera and the mic. So be here. In 5 minutes we will continue. Let me open the app. Okay, just a second. Okay. Hello everyone, am I back? Can we continue? I'm sorry, I forgot my mobile. Can I carry my mobile? Just a second. Otherwise, I will not be able to see the chat on the Telegram. Some people are doing chat on the Telegram also, na? Some people are doing chat on the Telegram, na? Give me 1 second. Give me just 1 second. I will be back. Hannah, it's there only on the table. Just a second. I guess we can continue. Okay. So let's continue with the next chapter quickly. Okay. With the preventive obstetric, pediatrics, and geriatrics. So I will start with the obstetrics first. Okay. Let me open the group. Okay. So let's start it. Okay, Ji. Okay. So let's start with the new chapter. So let me tell you what is antenatal care. Here we will see the three care: antenatal, intranatal, postnatal. In the obstetrics, we will see the three care: antenatal, intranatal, postnatal. Antenatal care is the care during the pregnancy, during the gestational period of pregnancy. Intranatal is during the at the time of the delivery, and postnatal is after delivery. Okay, so let's start with antenatal care. ANC, antenatal care. Care of the mother during pregnancy is known as antenatal care. It is the care between the as soon as it start after conception till labor. So during the gestational period, during the pregnancy, this care is given. It is given by health worker female to the lady. Okay, so that is known as antenatal care. You can see. Okay, so how many visits are required? Ideally 14 visits are required by the pregnant lady. Okay, from 0 to 7 month, every month once a visit. So 7 visits are these only. In the 8th month, twice a month, every 15 days. So two visits are required in the 8th month, and in the 9th month onwards, 9 months, 9 days, once a week. So 4 to 5 visits are required here. So 7, 8, 9, 10, 11, 12, 13 or 14. And 9 months, 9 days. So ideally 14 visits are required. All the pregnant ladies should visit the healthcare provided 14 times during the entire pregnancy, during a normal, uncomplicated pregnancy. Ideally, but no one does so. No one do so, especially in the periphery, in the villages. They don't do so. So minimum is 4 visit. Minimum. This is ideal. If they ask you ideal, go with the answer 14. Ideal is 14, but minimum is 4. So first antenatal visit should be early registration. As soon as possible after pregnancy, the pregnancy should be registered. Okay. The second antenatal visit is between 14 to 26 weeks. Third is between 28 to 34 weeks, and fourth is 36 week onwards till term. Any time will work. So these are the minimum four. Minimum 4. Okay, got it? According to Government of India. So these are the minimum 4. So if they ask you ideal, go with 14. If they ask you minimum, go with 4. Read the question and tell me the answer. How many minimum visits are required? Antenatal visits are required according to MCH, maternal child health care. So what is the correct answer? Of course, the 4 visits are required. Just now I taught you. So you get frequently questions on that. If you're getting ideally, answer will become 14. Okay, you should know that. Calorie requirement during pregnancy I have discussed yesterday. You want me to say it again, or you already know that? It depends on the type of the lady who is pregnant. Pregnancy can occur in anyone: a sedentary female, a moderate worker, moderate labor or worker, and an intense working female. Any one of them can be pregnant, right? So what is the calorie requirement? You should know the calorie requirement of a non-pregnant female. Yesterday we have seen. So it is 1600, 2100 and 2700 for sedentary, moderate and heavy. During pregnancy, additional 350 are required. So add 350, 350, 350 here. And during lactation, additional 600 is required in the first 6 months of lactation. So add 600, 600, 600, and later on after 6 months, additional 520 is required. This table I told you yesterday. Does everyone was there yesterday? So you have to learn the calorie requirement during pregnancy. And a male is not concerned here. I've already discussed the male yesterday. I guess you know how to make this table. Does everyone know, or anyone is new and want me to repeat this table? You know the calorie requirement according to NIN Hyderabad. Yesterday we have completed it. So please learn it. During pregnancy, I'm revising you. Yesterday we have already seen additional 350 calories required. And during lactation, additional 600 and 520. So whatever is the requirement, add this much of them in that. Everyone got it? Anna? So this is calorie requirement. So please learn, during pregnancy, additional 350, during lactation, during the first 6 months, additional 600, and during later on 6 months, it's 520. So you have to add these figures in 1600, 2100, and 2700, depending what type of worker female she is. Is it mild, moderate, or intense? Okay, that is sedentary, moderate, or intense. So you have to add additionally. Okay, regarding the protein requirement also, I told you yesterday. All the non-pregnant females require 46 gram of protein per day, non-pregnant. But during pregnancy, during first trimester, it's 46 only. During first trimester, no additional protein is required. But during second trimester, additional 9.5 grams are required. So add 46 plus 9.5. And during the third trimester, additional 22 is required. So add 46 plus 22. Whatever is the answer, you can write it down. So 46 plus 9.5, it will be 55.5. And here it will be 46, 56, 76, 78. So you can learn like that. And during pregnancy, during lactation, during the first 6 months, it's additional 17 and additional 13. So this is the protein requirement. You have to add everything in the 46. Additional, you have to add in the 46 and say the answer. Got it? So 46 plus 9.5, 46 plus 22, 46 plus 17, 46 plus 13. So this is the protein requirement yesterday we have seen. Say yes. So I have already told you protein requirement during pregnancy, additional 9.5 or 22, depending on the trimester. During first 6 months of pregnancy, it's 17. During later on 6 months of the lactation, it's 13. And regarding the calcium is not required extra. During pregnancy also, during lactation also. Calcium requirement of a female is 1200 milligram. It's always 1200. Whether the female is pregnant, lactating, non-pregnant, doesn't matter. But iron requirement is more. So during pregnancy, it's 35. And during lactation, it's 21. Okay, so you have to learn these figures if you can. Read the question and tell me the answer. Please read the question and tell me the answer. The extra calorie allowance needed per day during pregnancy. How much extra energy is required during pregnancy? Additional 150, 200, 300, or 350? I'm asking you. What is the correct answer, please? Yes, Aditi, you are right. Shivangi, you are right. You all are right. Karthik, Prabingal, you all are right. Very good. So additional 350 kilocalories. You all are. Repeated asked question. Many times it is asked. So that is the calorie requirement and the protein requirement during pregnancy and lactation we have finished. Now let me tell you, during antenatal visits, what services you will provide to the expecting mothers. So you are saying ideally the mother should come 14 times and minimum she should come 4 times to the healthcare provider. So at the PHC, what care you will give to this mother? She is pregnant. What all services you will provide? We will provide 7 different type of service. Number 1, we will do certain investigations at the subcenter. Number 1, first we will confirm the pregnancy using urinary pregnancy kit. So it is known as Nishchay. It is provided free of cost to the lady. The name of the kit is Nishchay, and it is free of cost. We don't cost anything for that. It's a pregnancy kit. It is known as UPT, urine pregnancy kit, urine pregnancy test. So for this, the kit is provided to the lady and we will confirm the pregnancy. We confirm there is a control line, test line, and we will confirm. So few drops of urine are to be put in the sample pad and after 5 minutes, the results are visible. So number 1, that is free of cost. We will test for malaria. We will test the hemoglobin of the female by Sahali's hemoglobinometer and we will see whether she is anemic or not anemic. We will test the urine for sugar and albumin. We will see whether the lady is not diabetic during pregnancy and we will ask the lady if she give the consent. We will test for HIV, but HIV testing is depending on the consent. If she give the consent, then only we test, otherwise we will not test. So that is proposed, that is not compulsory. But urine pregnancy test, malaria, hemoglobin, and albumin and sugar in the urine, that compulsorily we test on the first visit and we will do this investigations. Got it? As soon as we come to know that the lady is pregnant. So that is the services we are providing to the lady. Number 1. Number 2, these are the services we provided sub-center. You know the chain, no? First there is district hospital, then CHC, then PHC, then sub-center. I told you these are the services at sub-center, the minimum, the basic, these are the services. At PHC, a little bit additional services we give. So at PHC and CHC, we will do the blood grouping also to know whether it is not a case of erythroblastosis fetalis. I guess you know there are 4 types of blood group, A, B, AB, and O. Each of them is of 2 types, positive, negative, positive, negative. By positive, negative, I mean RH positive, RH negative. You know the RH blood grouping is there. You know the deadly combination. A female who is RH negative, should not marry a male who is Rh positive. This combination is deadly. They should not get married. If they are getting married during pregnancy, the first child will be okay. But later on, all the pregnancies, the child will have intrauterine severe hemolytic anemia and the child will die. The name of the disease is erythroblastosis fetalis. So that's why we are testing the blood group of the mother. Whether it is a case of erythroblastosis fetalis, we want to rule out number one. Number two, we will be ready with the blood group if during delivery she require additional blood. So we should know the blood group of that lady. So we will write in the card what is the blood group. Okay, we will do VDRL for syphilis, we will do HIV, we will do hepatitis B, and we will do random blood sugar. Here we have tested the sugar in the urine at subcenter. Here we will test it in the blood. Okay, so these are the additional investigation we are doing at PHC. We will give lady the iron folic acid tablets. These are free of cost. We will not cost her. Hannah, we will give these tablets free of cost. Each tablet contains 16 milligram of iron and 500 microgram of folic acid. This is milligram, this is microgram. This is 60 milligram, this is 500 microgram. Each tablet contains this. Hannah, because anemia is very common in India. Hannah. And during pregnancy, further hemoglobin decreases. We know that. Hannah. So we will give from the day 1 of the 14th week to 6 month. From 14th week to 6 month. From the day 1 of the 14th week to 6 month till post delivery. So nearly net of 365 days. We will give iron tablets. Okay. So we will give continuous iron tablets. Okay. If the hemoglobin is more than 11, we will ask the lady to take 1 tablet in a day. If the hemoglobin is less than 11, we will ask the lady to take it twice a day. So that is provided free of cost. How many of you got it? Got it? This is the iron tablets we are providing. The third service we are providing. The antenatal pregnant females at PHC, we are providing these services. Number 4, we will give tetanus vaccine. You know, all pregnant ladies should be given tetanus vaccine. So we will give tetanus vaccine to all the pregnant ladies. How many doses you want to give? You want to give total 2 doses 1 month apart. So whatever is the date, just suppose today is 10th of August. So today we are giving first dose. So 10th of September, we will give the next dose. And exactly after 1 month. So first dose is given as early as possible after 3 months. First trimester is completed. At the beginning of second trimester, you give first dose. And after that, after 1 month of the first dose, give the second dose. Hannah, give the second dose. Okay, got my point. This is for the first pregnancy. If she is having subsequent second, third, or fourth pregnancy, Hannah, and she is already given the tetanus in the first pregnancy, and first pregnancy is within 5 years. So don't repeat, only 1 dose booster is required. Got my point? The lady is pregnant for first time, give both the doses. The lady is pregnant for second, third, fourth time, more than 5 years, again give both doses. But within 5 years, if she got pregnant again, then only 1 dose is required. Because if you are giving full dose now, both the doses, immunity will last for 5 years. No need to give it again within 5 years. If she got pregnant again within the 5 years, give only booster. So these are the rules. Hannah, what if the mother is directly coming me at the time of the delivery, at the time of the labor? It's very common in the village peripheral deliveries. They directly come to you, present to you at the time of the labor pain. So pura time kahan the aaj tak nahi aaye, not even 1 visit. Hannah, so what to do at that time? So at the time, just before the delivery, give 1 dose at least. Hannah, no mother should be denied of tetanus even in late pregnancy. If she is coming very late, at least 1 dose you give. There is no possibility that after 1 month, just suppose lady is directly coming in the 9th month. I know delivery is going to happen in the next few days. So whether I should give 1 dose or not, because second dose I cannot give. It will not hold for 1 more month. Hannah, but at least I should give one dose. Got it? This is the thing. Hannah, and if the mother is unimmunized, you cannot give, or partially immunized during pregnancy, the infant should be given immunoglobulin. Hannah, 750 units within 6 hours of the birth. Say yes, say something. This is all regarding the tetanus vaccine. The next is deworming. Sometimes worms are very common in the intestine. By worms, I mean the parasites. So parasites are common and they can harm the baby. They can harm the fetus inside that. So deworming is done in the pregnant lady. We will give metronidazole, drug of choice. Albendazole is contraindicated. We don't give albendazole. We give metronidazole for deworming. We give calcium twice a day. Total 1 gram per day. So 500 ke 2 tablets. We will give calcium free of cost. We will start from 14th week of pregnancy till 6 months. Till 6 months postpartum after the delivery. So 14th week of pregnancy, yani ki lagbhag, we will start at 3 months, 3.5 months. And throughout the pregnancy and after delivery till 6 months also, we will give free of cost calcium. Okay. And referral services. Okay. So we will make a card. These are known as MCP card. Hannah, what is the full form of MCP? Mother Child Protection Card, MCP card. You can see Matra Bal Suraksha Card, Mother Child Protection Card. In English, it is known as, in Hindi, it is known as. So this is the logo. You can see. We will make a card. There are two types of card available. Okay, green and red. So here you can see the green color. Green means normal pregnancy. It's normal. Nothing is complicated. Simple, normal pregnancy we are expecting. And red is high risk. So we will give a card and we can refer. The lady will go like we are seeing at sub-center. So if we are referring at PHC, the lady will go with the card. We are referring at CSC, the lady will go. And if we are referring at the district hospital, so she will go with her card. Hannah, and this is again, that is green and red, two types of card are there. Got it? What you are asking? Mebendazole. By mistake, I told you metronidazole. It's mebendazole, not albendazole. Albendazole ka bada bhai hai. Mebendazole, the same category. Okay, got it? Can we go ahead? So these are the 7 services you have to provide A and C. Nothing to learn. So what are red? Red card you will give to high risk pregnancy. Can you define what is a high risk pregnancy? To which pregnancy you will say it's a high risk pregnancy? It's not normal. It is having some red flags. So what is that pregnancy? There are 14 conditions. Any pregnancy in which the pregnant lady is less than 45 kg, underweight, less than 45 kg, the mother, the pregnant lady, I mean. Anna, so she is a high risk pregnancy. Okay, when the height is less than 145 centimeters, she's short, she's underweight, or she's short in height. Again, that is high risk pregnancy. She's severe anemic. Twin pregnancy, all twin pregnancy is high risk. All breech pregnancy, you understand what is breech, I guess, it's high risk. Hannah, previous history of cesarean section, it's high risk. Diabetic, systemic disease like diabetes, hypertension, it's high risk. Already 4 times she become pregnant, and this is the 5th time onwards she is becoming pregnant, it's high risk. Hannah, the age of the mother, first time she is pregnant and she is more than 30 years. And multiple times she is pregnant and she is more than 35 years. Both are high risk. Hannah, infertility treatment, the mother is on, and first time she got pregnant after that, it's a precious pregnancy, high risk. Hannah, 3 or more abortions are done in the past, and now she become pregnant again, it's a high risk. Post-term pregnancy. Okay, post-term pregnancy, antepartum hemorrhage, that during the pregnancy she is bleeding, pervaginal bleeding, okay, and eclampsia. So you can understand, I guess no need to learn. Looking at the option, you can identify these are the high risk pregnancy. Again, you will read the same in obstetrics. Okay, obstetrics mein ye. So these all are high risk pregnancy. I told you the 14 conditions you should be able to enumerate for the high risk pregnancy. Can we go ahead? Read the question, tell me the answer. We are done with antenatal services. I told you 7 antenatal services. As soon as the lady is coming, do certain investigation at sub-center, refer her to PHC and do certain investigation at PHC, give tetanus toxin, give iron folic acid tablets, Anna, what else? Do deworming, Anna, deworming, what else? Give calcium, what else? So these are 1, 2, 3, 4, 5, 6 and referral services. Make card, red or green card. What is high risk pregnancy? I told you in that case you have to make the red card. So these are the 7 services you are providing antenatal care. This is the antenatal care. How many of you got it? Read the question, participate. So there is a 37-week pregnant woman attends antenatal clinic at the PHC. 37-week pregnant. She is not had any antenatal care till now. First time she is coming to you at directly 37 week. Anna, she is about to deliver. Okay. The best approach regarding tetanus vaccine, what you will do? Give at least 1 dose of tetanus vaccine and explain to her that it will not protect the newborn. It will not, and she should take the second dose after 4 weeks, even when she delivers. Do not waste TT, and it is of no use anyhow. Or give 1 dose of TT and explain that it will not be useful for this pregnancy, but for next pregnancy we are giving this one. Or give her anti-tetanus toxin, immunoglobulin, along with the tetanus vaccine. What approach you will follow? What is correct among them? I told you. So whatever late, if she's coming very late also, at least give 1 dose. At least give 1 dose. And give the second dose also even after delivery. Imagine at 37 weeks she is coming. Give 1 dose right now. In 38 weeks she delivered. Anna, but after 1 month, that is 4 weeks, at 40 week, Anna, you give second dose, she already delivered, but give the second dose also. Okay, so that is the approach, and newborn protection is not there. To the newborn, you have to give immunoglobulin. This is not giving, it is partial immunization. So you have to give immunoglobulin to the newborn. You all are right. It's A, not D. Nikita, it's not D. You will not give anti-tetanus immunoglobulin to the mother. You will give it to the newborn, I told you. Okay, so correct answer is A. How many of you got it? How many of you got it? Correct answer is not D, it's A. Everyone got it? Please everyone participate. Now if I'm asking something, at least respond. You got it or you have any doubt? Correct answer is A. Recommended dose of folic acid during pregnancy. I told you we provide iron folic acid tablet. So how much iron, how much folic acid in the tablet? I told you iron is 60 milligram and folic acid is 500 microgram per day. So it is 500 microgram per day. What is the correct answer here? The correct answer here is 500 microgram per day. Okay, I'm asking for folic acid. Okay, so we are done with antenatal care. Now it's time to deliver the lady. We have given 7 services free of cost to the lady. We have done certain investigation, that is pregnancy test, sugar in the urine, blood grouping. I told you, so 7 services you already know and the details of them. Now it's time to deliver the lady. She is in pain, labor pain, or she is not in labor pain. Even it's time to deliver like LSCS. So during intranatal care, intranatal is at the time of the delivery. We have to take care of clean and safe delivery. For safe delivery, there should be followed. We should take care of 5 clean. Number 1, the surface on which we are going to deliver the lady. Can you see the stretcher, the surface, the bed on which we are, the labor room in which we are asking the lady to lie down and we are going to deliver her. So that should be clean. A new bed sheet, disposable, sterile should be there on that bed, on that whatever the bed you are asking the lady to lie down. Okay, so clean surface, first requirement. Number 2, clean hands of the attendant. If you are the birth attendant, local dai is there, Asha is there, whosoever is there, that should wash their hand thoroughly. Okay, so either dai or the medical officer, okay, they can do the birth attendant. So proper, they should wash their hand. Clean cord cut once the baby deliver. So can you see, this is the cord, this cord has to be cut with a new sterile blade. This is clean cut. It is not any blade, anything with anything you can cut. No, infection will occur. So clean cord cut, new blade or any instrument which is sterile. With that sterile instrument, with the sterile scissor, you should cut, or preferably with a new blade, the sterile blade, I mean. Okay, clean tie. You are tying with a thread. Now this is the thread. You will tie the cord with a thread. So that thread should be sterile. A new thread that should be sterile. And the stump, clean cord stump, no applicant. So whatever after that you have tied, and you will leave the stump. Whatever remaining there after tying, it is a stump. Don't apply anything. Some people apply oil on that, some apply this, that. No, don't apply anything. Don't touch that. Don't apply anything. So clean stump should be there, no applicant should be there. So these are the 5 cleans. Can you enumerate the 5 cleans? Clean surface, clean hands, clean cut, clean tie, clean stump. Can you say it out? All 5 photographs are in front of you. These are the 5 cleans. So for clean surface, a new plastic sheet should be used every time, disposable. So after the delivery happen, take out this plastic sheet and discard it, and use another for another lady, which you are going to take in the labor room. Clean hands with the soap and water. The birth attendant should thoroughly wash the hand before doing the delivery, before conducting the delivery. Clean cord cut with a new razor blade every time. Clean tie with a clean piece of thread, sterile thread. And clean cord up means nothing had to be applied on the stump. Got it? These are the 5 cleans. But nowadays we say कि 3 भी चलेंगे, minimum 3 चलेंगे. Minimum 3 तो होना ही होना चाहिए. The surface, the hands and the cord. तीनों cord को एक साथ कर दो. Cord cut, cord tie, cord stump. So you can compile it 3. So no need to learn 3. You will get confused. Forget it. 5 are good enough to know. And nowadays we are working on the 7 cleans. We add 2 additional. So clean delivery surface, hand, cord cut, cord tie, cord stump is already there. But we want to add 2 more things extra. Clean water and clean towel for hand washing. The birth attendant is washing the hand now. So just suppose I'm washing the hand very thoroughly, but there is no towel. So with wash, I should wipe my hands. So there should be a clean towel also in that room. Clean towel should be there. And the water with which I'm washing the hands, that should also be clean. So now currently it is a recommendation. It is suggested. It is not yet done. So 5 cleans are already there, but 2 are recommended more. So total 7 cleans we are working now. How many cleans? So I want clean water and clean towel also, along with these 5. 5 to palace hai. So say all 7 cleans with me. Can you say the 7 cleans, please? Clean surface, clean hand, clean cut, clean tie, clean cord, clean water, clean towel. How many of you got it? These are the 7 cleans. Usually we say 5, but 7 is the recommendation. So read the question and tell me the answer. Which of the following is not included in the 5 cleans in intranatal care? Not included. Clean hand, clean perineum, clean cutting, clean surface. What is not there? Yes, Prabingal, you are right. Everyone is right. What about others? Yes, yes, yes. Very good. Very good. You all are right. Yes, doxycycline, you all are right. So correct answer here is clean perineum. Perineum clean is not a prerequisite, but others are already there. Yes, very good. So you get question on that. We are done with antenatal care. We are done with intranatal care. And now it's time to do postnatal care. In the postnatal care means after delivery. After delivery, how many visits are required? 4 visits. 4. है ना? So 4 visits. The first visit on day 0. Day 0 means on the day of the delivery. The second visit on day 3. है ना? Or 1 day after that. Alternate day. So today delivery is done. So 1 day after that, the visit is required. Third visit on day 7 from the day of the delivery. And fourth and last visit on day 42. Day 42. So day 0, 3, 7, 42. Learn 0, 0, 3, 7, and 42. 0 is the day of the delivery. So first visit, if there is a home delivery, now the first visit should be done by Asha on day 0. The second visit, again, all the visits by Asha, day 3, 7, and 42. Okay, so all the visits are taken either by Anganwadi worker or female healthcare provider or by Asha. Okay, this is the postnatal care. We are done with obstetric cares. I taught you preventive obstetrics, in which I taught you antenatal care, I taught you intranatal care, I taught you postnatal care. Here I taught you ideally 14 visits are required. When I told you minimum 4 visits are required, you have to learn the weeks. Not only this, I taught you the 7 services which we provide free of cost to the pregnant ladies. In the intranatal care, I just taught you 5 cleaned and 7 cleaned. You know what are 5 cleaned? Clean surface, clean surface, clean hands, clean surface, clean cut, clean tie, and a clean stump. And 2 additional we are adding here. These 5 are there as it is. 2 additional we are adding clean water and clean towel. So that you have to learn. That's it. And in the postnatal care, just learn 0, 3, 7, 42. The 4 visits are required. That's it. So that is the obstetric care. You get usually questions on antenatal, intranatal, postnatal care. I guess everyone is comfortable till now. Can we go ahead? So let me come on a little bit on the pediatric portion. Pediatrics. So let me come on the birth of the infant. Birth of the infant weight. I mean the infant weight on birth of an infant. Birth weight of an infant. Birth weight is the single most important determinant of the chances of survival of an infant. Okay. Low birth weight, the definition is any infant, the birth weight is less than 2.5 kg. And when the birth weight is less than 1.5 kg, it's known as very low birth weight. So what is the definition of low birth weight and very low birth weight? Low birth weight, very low birth weight. So ideally, all the infant who are just like infant is born, newborn is born, I mean, the weight should be more than 2.5 kg. If it is less than 2.5 kg, it is LBW. If it is less than 1.5 kg, it is VLBW. Got it? The female who do smoking during pregnancy, their babies are 170 grams less as compared to peer age group. Peer babies of the same age group. Got my point? So their babies, the birth, the newborn weight of smoker mother, the newborn weight is 170 gram lesser. If she don't smoke, the birth of the weight of the baby at birth is more, so 170 gram is more. Got my point? I guess you get it. So that is LBW. There are 2 type of LBW. Please understand it's difficult. There are 2 type of low birth weight. What do you mean by that? Preterm babies and small for date babies. What do you mean by that? I will draw 2 uterus in front of you to explain you preterm and small for date. I will teach you 2 types of LBW. Okay, let me draw a fetus here. Let me draw a fetus here. You can see this is the placenta. This is the placenta. Okay. Now, as you know the rule, I guess everyone knows, as the gestational age keep on increasing, the weight of the fetus keep on increasing. Just suppose the gestational age is 28 week. So there is a particular weight at 28 week. And after 28 week, when it becomes 29 week, 30 week, 31. So gestational age keep on increasing. The weight of the fetus also keep on increasing. We know that it's corresponding. So gestational age is directly proportional to weight of the fetus. How many of you agree? As the gestational age go ahead, the weight of the fetus go on increasing. We know that. So let's talk for the 2 things. Okay. Imagine the first baby. The first baby is corresponding with the gestational age. But the only thing, the baby born premature. The baby born premature. Ideally, the birth should be after 36 week of pregnancy, but before 36 week, the baby is coming out. before 36, that is premature, है ना? So baby is coming at 30 week, 32 week, so weight is less. It's not ideally it should be 2.8 kg at birth. It's less than that. It's less than that. The baby is LBW, but it is corresponding with that age, है ना? So 32 पे जो होना चाहिए वो है, बट ऑफकोर्स वो 2.8 से कम है, क्योंकि 2.8 तो तब होता जब 36 पे आ जाता बेबी. 36 से पहले आ गया तो वो 36 से कम है, but it is corresponding with the gestational age. It is known as premature baby. Maturity is less, premature. It is coming prematurely out. And second is the weight of the baby is less than the gestational age. It is not corresponding with the gestational age. The gestational age is whatever. The gestational age is 30, 36, whatever. The weight of the baby is less than that. Hana, this is known as IUGR, intrauterine growth retardation, or it is also known as small for date babies, SFD. How many of you got it? Both of them are LBW. Here also the weight of the baby is less than 2.8 kg. Here also it is less. But here it is corresponding with the gestational age. Here it is not corresponding. It is less than the gestational age. It is 10 percentile less than the gestational age. How many of you got it? I'm asking. I'm asking. Yes. So premature preterm Elizabeth, it is coming out early. That is the only problem. But it is corresponding with the gestational age. Got it? Anna? So preterm babies and small for date babies. Preterm babies are born before 37 week completed. That is the problem. But they correspond with their gestational age. So if they are bonding at 30 week, the weight is of 30 week only. If they are bonding at 28 week, the weight is of 28 week only. So that is preterm. They are born too early. That is the only problem. उनको बाहर आने की जल्दी है ना? तो वो जल्दी बाहर आ गए. But gestational age से उनका weight correspond कर रहा है. Intrauterine growth is normal. Their weight, length, development may be within normal as compared to the gestational age. है ना? तो इनमें catch up is very fast. After coming out, they frequently do catch up very fast. And the small for date babies, these are term or preterm. ये पूरे term पे भी बाहर आएंगे ना. 37 week only they are coming. Still their weight is less. They are coming before that, their weight is less. Their weight do not correspond with the gestational age. It's less than 10 percentile of that. So there is intrauterine growth retardation, and here catch-up is slow. How many of you got it? So preterm babies, here intrauterine growth is normal, gestational age corresponding. And here small for date babies, intrauterine growth is retarded. Here they do not correspond with the gestational age. How many of you got it? These are the two types of LBW. Read the question and tell me the answer. According to WHO, what is the definition of LBW? What is the definition of LBW? Can you explain the definition of LBW? Low birth weight less than 2.5, birth weight less than 10 percentile, gestational age less than 34, or gestational age less than 28. I'm asking you. What is the correct answer, please? Yes, the birth weight less than 2.5. Now, whatever is the reason. Reason is preterm or reason is small for date. Both of them are LBW. So LBW is of two type. Low birth weight babies are of two type. What are the two types? Preterm, they come early, है ना, before 37 week. And the second is small for date babies. Okay, in both of them, the birth weight is less than 2.5 kg. But the reason is different. Here they correspond with gestational age. Here they do not correspond with gestational age, less than the gestational age, 10 percentile less than the gestational age. But both of them, one thing is common, both of them are less than 2.5 kg. I guess you got it. Read the question and tell me the answer. VLBW, very low birth weight babies. What is the definition? Less than 1,000, 1,500, 2,000 or 2,500. What is the correct answer? I'm asking for VLBW. So you all are right. VLBW is less than. So if I ask here, LBW, answer is 2,500. And VLBW, 1,500. So any baby who is less than 2.5 kg is LBW. Okay. And any baby who is less than 1.5 kg, it's VLBW, very low birth weight. So this is the answer. Okay. What is the most common cause of low birth weight babies? Prematurity, infection, anemia, or diabetes. I told you, no, there are two types of low birth weight babies. Preterm, that is premature, and SFD. So preterm, the prematurity is the most common cause. The most common cause is prematurity. Can we go ahead? Now let me tell you a term, that is kangaroo mother care. Have you heard about it? Kangaroo, skin to skin care given to the baby. When the baby is LBW, now what is the way to increase the weight quickly and cheaply, without doing much, so you can keep the baby to the incubator. So in the ICU, in NICU, in NICU, incubators are there. When the baby is very low birth weight or low birth weight, So, you know, the skin is not very good developed. So in the skin, the subcutaneous tissue is not there, the fat is not there. So baby is prone to develop hypothermia. The baby can go in hypothermia, especially if the babies are born in winters. So in November, December, January, February, the cool months, we have winters. You know? So whenever the winters are there and some baby LBW is born, imagine the skin is not developed, that there are high chances baby will go in hypothermia and die. There are high chances. The baby cannot maintain the temperature. I know it's very difficult to maintain the temperature. So we have to keep such babies in the incubators. And incubators, you may have seen the incubators, they are very costly, but you have to keep the baby in ICU, NICU. So what is the best incubator? The mother. And mother can give direct skin to skin touch to the baby so that the warmth of the mother can be provided to the baby all the time. And this is known as kangaroo mother care. So kangaroo mother care, it was introduced in Colombia by a Dr. Hector Martinez and Adzarre. So these are the two names you should know. This is the doctors who have introduced kangaroo care in Colombia for the first time, placing the baby between the breast of the mother, between the two breasts of the mother to provide direct skin to skin contact. You can see. So placing the baby between the breast of the mother so that direct skin to skin care should be given to that to, to provide the adequate temperature, to maintain the temperature of the baby. This is the natural and the best incubator. And no costing is required, of course. Okay, and mother can give the best care to the baby. So this is kangaroo care. So this is a kangaroo cloth is available in which the baby should be tied here on the waist of the mother like this. And the mother can do the kangaroo care by routinely doing at the home only. No hospital admission is required. If you can teach and train the mother, train the mother and you can discharge. You can train how to give the kangaroo care and you can do the discharge. So hospital admission is not required. So less burden financially, hospital admission is less, early discharge is there, and costing is also less, and best care is given. This is how you can see a low birth weight baby, how the mother is giving the kangaroo care. Okay, so that is the best care, the kangaroo care can be given. Okay, all the babies should be given kangaroo care till they maintain the weight of at least 2 kg. 2 kg ke upar they are stable now. All the babies below 2 kg, they should be given kangaroo care. Okay. So kangaroo care is an early, prolonged, continuous skin to skin contact between the mother and LBW baby. The best care, right? It should be given for 24 hours a day. But how a mother can give 24 hours? She has to do something. Sometimes she wants to sleep. She wants to do the rest. In that case, the father can also give. The other family members can also give the kangaroo care. It's not only mother can give. Maximum mother should be given, but the father and other family members can also give the kangaroo care. But it should be given for 24 hours to the baby. Okay, so that is the thing. So what are the benefits? It will provide warmth to the baby. So baby, it is preventing hypothermia in the baby. Good growth is promoted. So anytime the mother do the breastfeeding also, the baby is close to the breast and anytime she can give the breastfeed to the baby also. So exclusive breastfeeding is also promoted with this way, and it protects the baby from the infection. Cross infection in the hospital. You will give early discharge. Now you will ask the mother to take a discharge. Don't stay in the hospital. If you keep the baby in the incubator in the ICU, the mother will also stay in the hospital. The baby will also stay in the hospital for 1 month, for 2 months, till the baby will gain the weight till 2.5 kg. Here you don't have to do anything. Train the mother and discharge them. So hospital cross infection ke chances nahi hai. So these are the advantages. How many of you got it? This is known as KMC, kangaroo mother care. Okay ji, kangaroo positioning not required. But the baby should be kept on the chest of the mother between the two breasts, and the neck of the baby should be held on one side, either right or either left. It should not be central, otherwise it will compress the nose of the baby and baby cannot breathe. So move the neck of the baby to one side for few hours, then other side for few hours, like that. You have to change it. So it should be kept on the chest of the mother in vertical position, and the head should be turned to one side. You can see, and it is known as frog-like position. The hips and the knees should be flexed. You can see the hips and the knees should be flexed like that in a frog-like position. And that's it. This is kangaroo position. That direct skin to skin touch should be there. Between the baby and mother, no cloth. Direct skin to skin touch. Okay, that's it. And the mother can wear a dupatta and it should be for 24 hours. Got it? Can we go ahead? That is KMC. Can we start the next topic? Okay. Yes, of course. Who is asking this? I cannot read your name, but yes, it should be given to LBW as well as very specially in the VLBW. Mein to dena hi dena hai. There is no other option. You have to give in VLBW. LBW, BLBW, both of them should be given. And minimum, the weight gain should be at least 2.5 kg ho tab tak, or at least 2 kg ho tab tak to dena hi dena hai. Imagine the baby who is born only 1200 grams, only 1000 grams. They are very small kids. They are very highly susceptible for hypothermia, infections. So to them, you have to give till the weight gain. If you keep them in the incubator, it will require a month. So admission in a month, it is a big burden, financial burden on the family. So better than that, train the mother for kangaroo care. It's cheap, it's easy, and it increases the bonding between the mother and the baby also. Can we go ahead? The next topic is the congenital disorders in the newborn. How many congenital disorders you know in the newborn? Most common congenital disorders in the newborn is the heart disease. Apart from that, deafness and neural tube defects are also there. Okay, leave it. Coming on the feeding of the infant. Okay. Oh, incubator is required in a number of conditions, Dev Batra. I cannot enumerate it. That is the complete pediatrics you will learn. There is a subject pediatrics. Now you will learn in that. There are many conditions when incubator is required. Whenever there is a sick infant, you have to keep the infant in an incubator. Incubator is the ICU of the infant. And incubator is something that will maintain the temperature. So especially in low birth weight babies, it is required, but in many other conditions also you have to keep it. Okay, that is an isolation you want to keep the baby. Okay, so that is the thing. So it is a non-specific question. There is no specific list I should enumerate. Anyways, coming on the feeding of the infant. Can I come on feeding of infant? How to feed an infant? So human milk is the breast milk, and cow's milk is also available. Now there's a myth. You may have seen a taboo or a myth in many families. They believe that cow milk is better than the mother milk, the breast milk of the mother. Is it true? No, it's absolutely not. Absolutely not. It's not true. Breast milk is the best one. Cow's milk is for cow's baby, and breast milk is for human baby. The breast milk, the mother's milk is for human baby. You got my point. It is not the cow's milk is better for human baby. No, not at all. Not at all. But some people believe that. Let me compare the milk of the both. Yesterday, have I compared the milk? I told you a mnemonic also. Few mnemonics you also told me. I forgot. Hannah, this I told you. Yesterday, have I taught you this in the nutrition regarding milk? So all the things. If you talk about the protein content, this is the sequence. If you talk about the fat content, this is the sequence. Energy content, this is the sequence. Hannah, so it's buffalo, goat, cow, and human. Got it? Be genius in cow house. Okay, be a genius in a cow house. Whatever. Hannah, yes, baby girl in Chandigarh. Okay, so okay. So whatever the mnemonic you use, this is the sequence I told you. Hannah, this is for protein, fat, and energy. I'm interested in cow and human. I'm not taking buffalo and goat. I'm taking cow and human. So you will see, ma'am, everything is more in cow. I'm sorry. So everything is more in cow. The protein is also more in cow. The fat is also more in cow, and energy is also more in cow. But lactose, I told you, lactose wise human is first, है ना? So human में ज़्यादा होगा as compared to cow, है ना? So you will say, ma'am, why cow milk is not good as compared to human milk? Apart from lactose, everything else is high, na, in that. But human baby cannot digest that, है ना? I agree. You can see lactose. Lactose is more in human milk, but protein is more in cow milk. See the values. Fat is more in cow milk. See the value. Calcium is more in cow milk. See the value. Water is more or equal in both of them. Energy is more in cow milk. You can see the value. Hana? But Hana, in casein is again more. Casein and various issues again more in cow milk. Everything is more in cow milk apart from lactose. The first thing. Only lactose is the thing that is maximum in human milk. Rest all the things are maximum in cow. You can see the values. Hana, still I don't recommend human baby should be given human milk only. It should not be given cow milk. It is a myth because the digestive tract of the human baby can digest this only. It cannot digest this. This is according to the digestive tract of the cow's baby. That is a calf. It is for a calf, the cow's baby. It is not for human baby. For human baby, this is the milk. And also God has intentionally given such milk. Cow's milk is for cow's baby. Human milk is for human baby. So please remember. Got it? Yes, lactose is higher. Yes, bhai Goa chalte hain. Whatever mnemonic you want to learn, but learn that. Okay, ji, can we go ahead? Anna? Yes. So this is the same thing written in front of you. Yesterday we have discussed that in detail. So human milk is rich only in one thing, that is lactose. Lactose and iron also. Little bit iron also you can compare. You can see this is iron. Iron is also more in human milk. 0.2 and 0.3. Lactose and iron is more in human milk. And yeah, so that you have to learn. When breastfeeding week is celebrated, it's in August. So currently we are in August now. So this month is breastfeeding week. This month we are having breastfeeding week and we promote breastfeeding as much as possible. This is the August. In the August we celebrate it. Exclusive breastfeeding should be done for 6 months and it should be continued up to 2 years. For the first 6 months, from the birth of the baby till 6 months, nothing should be given to the baby apart from breast milk, mind my words, not even water. So it's again a myth in many families that child may be thirsty. So breast milk is giving only nutrition. We should give additional water. No, don't give anything. No food, no water, nothing. Nothing. You give exclusive breastfeed to the baby during the first 6 months. That is more than sufficient. The breast milk giving food, water, everything to the baby. Breastfeeding should be exclusive till 6 months, and till 2 years. Till 2 years, it should be continued. After 6 months, it should be supplemented along with the food. So you start feeding the baby external food like dal, pulses, and other things. At 6 months, you start other thing is the baby will start eating at 6 months. That is known as weaning. So breastfeed should be continued till 2 years maximum, according to WHO. Colostrum is the first milk. The first breast milk is thick yellow in color. It's very nutritious. It contains all 5 types of immunoglobulins: IgG, IgA, IgM, IgD, Ig. It contains everything. Hana, that's why it is very, very nutritive for the baby. So first breast milk, the thick yellow color, it should always be given to the baby. That is known as colostrum. Okay, so please learn that. And how much breast milk in ml? How much is the output of the breast milk in ml every day? So for the first 2 months, maximum 500 ml will come, half a liter. Okay, after that it will increase to 600, 700. Maximum is 730 maximum, and at 6 months it's maximum. And after that again it decreases. And first it increases. So at 6 months it is maximum. So if the mother is doing exclusive breast feeding throughout the day, every 2 hours she is feeding her baby. So maximum output in the breast of the mother, both the breast, 50% of this breast, 50% of this breast. So half of time she should feed from right breast, half of the time she should feed from the left breast. So total output is 730 ml is the maximum at 6 months. So this fits also. So as the baby is small, the hunger is less. So this much is sufficient. As the baby is growing, the hunger increases. So the God is automatically increasing the output also. So the ml of the milk is also increasing. At 6 months, it's maximum. After 6 months, why it is reducing? The hunger is keep on increasing, but you start other foods also, na? So again, it is decreasing. So you start eating, giving other foods to the baby. How many of you got it? Can we go ahead? Okay. Okay, can we go ahead? So Mahima, you are saying in some cases mother is not able to breastfeed the baby, then which is better? Then formula milks are available, which are mimicking the breast milk composition. Still, in that case, you should not feed the baby with cow milk, buffalo milk, or goat milk. No, formula milks are available. I mean, artificial, the containers. Many formula milks are available for the baby. And that should be given. They simulate the breast milk, but they are not exactly as nutritious as that breast milk because they don't contain the antibodies and all. Composition wise, lactose, it is equal, the protein is equal, but they don't contain the antibodies and other things. So that is the thing. Formula feed should be given in that case. But ideally, if the mother is working, express milk is also an option. It is not the physical availability of the mother should be there. The mother can express the milk. The pumps are available. With the help of the pumps, she can collect the milk in a bottle and keep it in the refrigerator. So anyone else in the family member, the grandmother or the father or anyone in the family member, the caretaker of the baby, that can later on feed the baby with the breast milk in a bottle. So breast milk can be given if the mother is available. Although the working mother, not full time, she is available with the baby. But if the mother is alive, no, it is a case the mother is separated, the mother is divorced, the mother is dead, the mother is not at all there, then it is a separate issue. In that case, formula feed is the best feed. Okay, so this is the answer. Can we go ahead? Okay, so let's continue. What are the disadvantages of exclusive breastfeeding? There are few disadvantages. Breast milk don't contain vitamin B, vitamin K, vitamin D, and fluorine. Four things are absent. Since vitamin K is absent, sometimes babies at high risk of hemorrhagic disease. In which babies, the vitamin K is already deficient and the baby is on exclusive breastfeeding. So hemorrhagic disease of newborn can occur. Vitamin B, K, D, and fluorine. These four things are absent in breast milk. Please learn that. So please read the question and tell me the answer. Please read the. Yeah, Aditi, milk banks are also available. In big cities, in metros, nowadays milk bank is a new concept. So it is available. Milk bank, like the blood bank, milk bank is available, where there are donor mothers. The mothers who have extra milk apart from feeding their babies, they are in lactating phase, and they have extra milk, which is more than the demand the baby is demanding. They have small kid, they are feeding their baby, still they have extra. So they can express it in a bottle and they can donate it in the milk bank, and they will get money like the blood bank only for that, a nominal money they will get. And from the blood milk bank, another people who don't have mother and they want to feed their baby with the breast milk, they can take it on money. Hana. So it is, I mean, based on the money, it will be available. Okay, so that is also a concept, milk bank. So in COVID, milk banks were very famous. Hana. So donors are there, recipients are there. So that is the thing. So can we go ahead? Read the question, tell me the answer. As compared to cow milk, breast milk contains what? More energy, more fat, more lactose, or more protein? You all have already answered, I guess. So correct answer is more lactose. Everyone agree? So only lactose is more in breast milk. Rest all the things are more in cow milk. Lactose and iron also. Okay. So let's come on the next topic, breastfeeding. We have seen the breast milk. Now let's come on the mechanism of the breastfeeding. So we know what is breastfeeding. It's a beautiful process between the mother and the child, you can see. So breastfeeding should be started as early as 30 minutes of the vaginal delivery and as early as 4 hours of the cesarean section. In the cesarean section, the anesthesia is given to the mother. So maybe within 30 minutes, it's not possible, but within 4 hours, it should be started. In normal delivery, it should be started within 30 minutes after the delivery. As soon as the delivery happened, within 30 minutes, it should be started, ideally. And in cesarean section, it should be started within 4 hours. So learn the two figures, 30 minute and 4 hour. 30 minute, 4 hour. Please learn that. It increases the bonding between the mother and the child. You can see the breastfeeding. Okay. Now there are two types. Now imagine you are hungry and you are thirsty. You are both. You are hungry also. Imagine it happens now, and we are thirsty also. So what do you want first? You want food or water? You want to satisfy your hunger first or satisfy your thirst first? Of course, common sense. We want to drink water first. First, water is necessary. We will satisfy the thirst. And that is unbearable sometimes, right? And after that, we are hungry, we can eat the food. The same occurs with the child. So whenever the mother starts the breastfeeding, the first milk which is going in the mouth of the baby, that is very thin and watery and contain lactose. So it's like a sweet water to satisfy the thirst, that is known as foremilk. So first milk which goes in the mouth of the baby, that is very thin. It contains abundant of water with sugar and minerals. So it's like a mineral water. We drink mineral water. So it's sweet mineral water. You can learn like that. Hannah, it will satisfy the thirst of the baby. Hannah, and after that, later on, the baby keep on sucking, keep on sucking. So later on, the milk that will go, that is hind milk. That is rich in fat, and that will satisfy the hunger of the baby. So first foremilk, then hind milk. So you can see what a beautiful process the God has given. So whenever baby starts sucking the breast of the mother, the first milk coming is the foremilk and later on hind milk. The foremilk contain more water and lactose and minerals to satisfy the thirst, and later on the milk contain abundant of fat to satisfy the hunger. Foremilk, hind milk. How many of you got it? Okay, storage of the breast milk. As I told you, the expression of the milk is possible. Expressed milk. Expressed milk, the pumps are available. The mother can take out the milk and collect in a container with the help of a pump, and that is known as expressed milk. So she is working. In the morning before going to the job, she is collecting it in a container and she want to store it, so that the father or grandmother or any other person available in the family, they can feed the baby later on, right? So at room temperature, if it is kept now, it can be kept only for 8 to 10 hours. After that, it will spoil and it has to be discarded. But in refrigerator at 2 to 8 degree, it can be kept for 24 hours itself. Hana, the complete 24 hour, it will be safe. It is good to give. Hana? And in freezer at minus 20 degree, it should be kept for 3 months. So in the banks, milk banks, breast milk banks, it is kept in freezer. I told you milk banks are also there. No? It's a concept. Got it, Hannah? You got it. So at room temperature, it's 10 hours. At refrigerator, in refrigerator, it's 24 hour. In freezer, it's 3 months. Hannah? Fridge and freezer. And at room temperature, it's only 10 hours. So 10 hour, 24 hour, and 3 months. Please learn the storage. These are your PYQs. Please keep on indicating that you are getting everything. Keep on giving your thumbs up or say something like you got it. Okay. Now, positioning is very important, especially in the prima mother. What is the prima mother? The mother, she got pregnant first time and that is the first baby. So she is not knowing that how exactly she has to do the breastfeeding. Hannah? So she is offering the breast nipple to the baby. The baby is taking the nipple to the mouth, but the positioning is not proper. Since the positioning is not proper, the baby is not getting any milk. So she is offering the nipple. The baby is taking the nipple also, sucking the nipple also. She is in dilemma that the baby already got the nutrition. But once she is like taking the baby away, the baby is again crying because baby is still hungry. Baby is not getting anything. So positioning is very important. You have to teach the positioning, especially the prima mothers, the first mothers. You have to teach the positioning. So they have to hold the babies like in their arm as close as to their body. And the main thing during positioning is that the lower lip of the baby should be everted. The lower lip of the baby should be everted. The baby is not taking only nipple of the mother, it is taking the complete areola also, the brownish skin also, the areola also, and the lower lip should be everted. It's not, this is wrong attachment. The baby is taking only the nipple, not the areola. The lower lip is not everted. This is proper. So chin touching the breast. The chin of the baby should touch the breast. Here, see the chin. Here, see the chin. This is wrong. So chin should touch. The mouth of the baby should be wide open, taking the nipple as well as areola. The lower lip should be everted. And more areola should be visible on the upper breast, not on the lower side. So these are the signs of the proper attachment. And being a doctor, so you should teach it, especially the obstetrician should teach it whenever the delivery is done. So during the first visit or second visit, the obstetrician should guide or teach or train the mother how to perform a proper positioning in the breastfeeding. And breastfeeding is very important. Tell the advantages also. So these are the signs of the proper positioning. Anyways, let's move ahead. What are the advantages? Advantages to the baby, advantages to the mother. The baby getting antibodies in the breast milk. So chances of infection are less, chances of diarrhea are less, chances of pneumonia are less. When they become adult, such babies who got the breastfeed during their childhood, they have less chances of developing diabetes in future. These babies have high IQ, those who got the breastfeeding of the mother, and they have a better dentation also. So these are the advantages to the baby. Of course, breast milk is always advantageous, beneficial for the baby, but not only for baby, it is beneficial for the mother also. By breastfeeding, mother is reducing her chances of breast cancer. The mother who perform more and more breastfeeding now, the chances of breast cancer in future are less. Okay, not only breast cancer, ovarian cancer. Such mothers are at low risk of developing diabetes in future and postpartum depression also. So these are the less chances in the mother. That's why it is beneficial for both. Say yes. So that is the thing. These are the advantages. Okay, so that's it. Read the question, tell me the answer. We are done with breastfeeding also. Quick, fast. Read the question, tell me the answer. In normal delivery, the breastfeeding should be started within how many hours? Within half hour, 1 hour, 4 hours, 6 hours. I'm asking in normal delivery, not in cesarean section. Prabingal. What is your answer? Yes, Aditi, Shivangi, Leah, you all are right. The correct answer is half hour. Okay, within half hour it should be started, not 4 hours. If I say LSCS, answer will become 4 hours. Instead of normal delivery, if I say LSCS, then answer will become 4 hours. But in normal delivery, it should be started within 30 minutes. Yes, 30 minutes of post-delivery. Exactly. So correct answer is A. Okay. It's wrong. Correct answer is A. Okay, within half hour or 30 minutes. Okay. Let me tell you an initiative which is known as Baby Friendly Hospital Initiative, BFHI. Baby Friendly Hospital Initiative. So this initiative is taken by WHO and UNICEF together. So it's an initiative, WHO and UNICEF initiative to promote the breastfeeding as early at the starting at the birth only. So what initiative? There are 10 steps in that. So let me tell you the 10 steps. So all the hospitals in which deliveries are performed, the nursing home, the hospital, the obstetric gynec nursing homes, and any hospital in which the deliveries are performed, they should follow this BFHI. They should follow the 10 steps. Number 1, again the same. The breastfeeding should be started within half hour, first hour or half hour in case of normal delivery, and within 4 hours of the cesarean section. That I already told you, this rule should be followed. Number 2, breastfeeding should be on demand. It should not be on clock. It should be on demand. Demand means when the baby cry, then only give the breastfeed. When the baby will feel hungry, baby will cry. And at that time, mother should offer the breastfeeding. It is not the thing some people say that every 2 hours it should be feeded, whether baby is crying or not crying. So mother make an alarm that every 2 hours I have to feed. No, it should be on demand. The baby should demand it. It should not be by clock, looking at the clock every 2 hours or 3 hours you are feeding. No, it's not there. So it should be on demand. You have to explain the mother. Rooming in, the mother and infant should be kept together. Should be kept together in one room. That is rooming in. All the mother and infant remain together for 24 hours a day, so that breastfeeding chances are more. Now, if you keep them in separate room, the chances of breastfeeding will reduce. Okay, exclusive breastfeeding for the first 6 months, not even water, no other food, no other drink. Exclusive, we know that. So this is the 4th rule. You have to explain all this to the mother and the family member. There should be no advertisement of any infant feeding there. And a Cerelac. Have you heard the name of the Cerelac and other infant foods? Cerelac is very common. There are many companies which are offering the infant food. And there should be no advertisement. If in your hospital there is a single advertisement of any infant feeding book, that's why you may have not seen any ad of the Cerelac till now on the television. It's not allowed. It's not allowed. They cannot replace breastfeeding. If any food, infant feeding is claiming that it is as good as breastfeeding and it is doing advertisement on the TV, radio, they will be under legal action. So it is not allowed to promote any infant feeding food. If the mother is not available, mother is dead, in that case, the doctors will always suggest, you don't have the mother, to take, like the family member, give the substitution food. But if the mother is alive, the breastfeeding is always promoted. Okay, so infant feeding, there should be no promotional advertisement of that in your hospital. Okay, if your hospital is doing so, you are under legal action. Got it? Show mother how to breastfeed, like proper attachment and all. Hannah, you have to teach it. There should be no artificial teats. Have you seen artificial teats? The artificial teats are the shape of the nipple only. They are the shape of the nipple like that, and they are filled with honey. They are filled with some liquid. They are filled with some juices, and they mimic the breast of the mother. Hannah, they are the shape of the nipple. So, and whenever the baby is crying, just give the artificial teat, artificial. So they are very infectious. You are keeping it here and there. It get contaminated. Again, you are putting in the mouth of the baby. Baby is taking and throwing here. Then again taking. So it is not advisable. Never it is advisable. Never, because it increases the chance of the infection. Okay, and encourage the mother to assist each other in the breastfeeding support group. You can make some WhatsApp group and some groups between the mothers, so they can be in touch with each other and they can support each other if they are facing some trouble. And there should be written policies in all the hospitals. Okay, and train all the staffs, your nurses and all the staffs for that. That's it. So this is baby friendly mother initiative, baby friendly hospital initiative, BFHI. Got it? BFHI. In India, BFHI is equivalent to MA, MAA MA. What is MA? Mother Absolute Affection Program. That is MA program. Okay, you can learn these names, catchy names. We are done. Read the four question and four options and tell me the correct answer. What are the guidelines of BFHI accept? I told you 10 guidelines, which is not a guideline. Read it. Mother and infant should be kept together for 24 hours. Is it a guideline or not? Mother should initiate the breastfeeding within 4 hours of normal delivery. Is it guideline or not? Giving newborn infants no other food, no other drinks in the exclusive breastfeeding in the 6th month, and encouraging breastfeeding on demand. Which of the following is not a guideline? Of course, among them, one is incorrect. This one is incorrect. It should not be 4 hours in normal delivery. In normal delivery, it should be in half an hour. In cesarean section, it's 4 hours. Rest, all the things are correct. I guess you got BFHI. Baby Friendly Hospital Initiative. Don't learn the 10 statements. You have understood it now. Dekho, we understood it. We can make the question. We don't have to write the 10 statements. You have to understand and pick it up in the option. So this is Baby Friendly Hospital Initiative. We are done. Can we go ahead? No, we are done. We are done with the feeding of the infants. Now coming on the care of the children. Care of the children. Okay, let me tell you, I told you at-risk pregnancy. I told you 14 conditions of at-risk pregnancy. Now let me tell you at-risk infant. Which infant is at-risk infant? Whenever the birth weight of any infant is less than 2.5 kg, that is LBW. Twins are always at-risk infant. Whenever the birth order is more than 4, 4 children are already there, and this is the 5th children, or 5th onwards, 5th, 6th, 7th children the mother is having. So mother will not be able to take care of the child much. So that is at-risk infant. Artificial feeding. The mother is not there, or mother is not giving the breastfeeding, and the baby is on artificial feeding. So that is the at-risk infant, high chances of developing infection. But birth weight is less than 70% of the expected weight. Okay, that is at-risk infant. Failure to gain weight in 3 subsequent months. So weight become increasing, then become plateau for 3 months. That is at-risk infant. PAM or diarrhea. Protein energy malnutrition. Working mother. All the working mother children are already at high risk. So at-risk infant and one parent. The other parent is separated, divorced, or dead. Okay, so these infants are high risk or at risk infant. Let's just read the conditions. You will make it out in the option. Any confusion? Any confusion? Now I am going to teach you the assessment of physical growth of a child. How you assess the physical growth of a child? You have to see the weight of the child, height of the child, head circumference, chest circumference, and mid-arm circumference. So these are the 5 things you have to measure. I will teach you all 5 one by one. Although this is a section of pediatrics subject, you will see all these again in pediatrics. But here in PSM only I am teaching you. right? So in pediatrics, you will have a revision again. Can I start? Are you people with me? So first I will teach you all the important points of weight, then height, then head circumference, chest circumference, and mid-arm circumference. You get many MCQs on that. Let's start with the weight, birth weight. Hannah, weight. What is birth weight? The weight taken within first hour of the birth. That is known as birth weight. Name the instrument on which we take the birth weight. Name the instrument. This is the instrument. It is known as Salter scale. What it is known as, for small babies, it's like this. Hannah, the baby will lie down. Keep the baby naked without cloths, because otherwise you will measure the weight of the cloths also. Put the diaper off, because diaper sometimes it's very filled with the urine and all. So sometimes 1 kg of diaper itself. Hannah. So keep the diapers off. Keep the baby naked to know the exact weight. Hannah. So this is the name of the instrument is Salter scale. Okay, it's a image based question also. For big babies, it's like this. Hannah, for big babies. So there is a jhula like thing. You have to put the baby in that. So it will show the weight like this here. You can see the weight is like. So for big babies, the one who can sit, it's like this. The one who cannot sit, it's like this. So this is Salter scale. This is Salter, both are Salter scale. The weight should be measured within first hour of the birth. That is known as birth weight, right? It is the single most important criteria. Hannah, you measure weight, height, everything of the baby. But the most important criteria the baby is going to develop, the baby is going to survive or not, it is weight. Weight is the single most important criteria that is going to decide the health of the baby ahead. Hannah, so that is the thing. Birth weight. Hannah, measured on Salter scale. You know the instrument also. Okay. The average weight in India is 2.8 kg. Less than 2.5 kg, it is known as LBW. Less than 1.5 kg, it is known as VLBW. Okay. During the first 10 days, the birth decreases. Yes, it decreases. On the 10th day, Hannah, it decreases. And because the newborn is losing the water, so it is decreasing by 10%. Hannah? Okay, so most of the full-term infants, and again is regained at 10 days. So today, just suppose today a newborn is born. And today the newborn weight is 3 kg, just on birth. So we are very happy, okay, the baby is not LBW, it is more than 2.5 kg. Okay, Hannah, for the next 10 days, at the 10th day, it is again 3 kg. And in between, it keep on reducing, and then again increasing. So at 10th day, it regain, because the baby is losing the water. So first 10% is lost. So 10% of 300 is 0.3. So it will become 2.7, and again it will become 3. This is the 10% loss, and then again 10% gain. So at 10th day, 10% loss as well as 10% gain. Again, it is same. How many of you got the story? So this is the birth weight. Hannah? So on 10th day onwards, it keep on increasing always then. Okay, उसके बाद reduce होगा तो मतलब malnutrition है. Okay, so from 0 to 3 months, every week the child gain 200 gram every week. I'm saying every week, 200 gram every week. From 4 to 6 months, 150 gram every week. है ना? And from 7 to 9 months, it is 100 gram per week. So 3, 6, 9, and 12, then 50 gram per week. Per week, है ना? Per week. There are 4 weeks in a month. So in a month, here it is 800. Here in a month, it will be 600, like that. Hannah, from 1 to 2 year, it is 2.5 kg per year. That's it. And from 3 to 5 year, it's 2 kg per year. You please learn that. Howsoever you learn, I don't know, but you have to learn. What I said, 0 to 3 month, 3 to 6 month, 6 to 9 month, and 9 to 12 month. 12 month is 1 year. So 1 to 2 year and 3 to 5 year. Okay. So please tell me how much is the gain in weight. So here it is how much? 200 gram per week, 150 gram per week, 100 gram per week, 50 gram per week. You can do the calculations. Hannah? So in a month, how much? In a 3 months, how much? 1 to 2 year, it is 2.5 kg per year. And here 2 kg per year. How many of you got it? Try writing it down. Once you write it down, it will be fitting in your memory. So you get questions on that. So tell me the question. Tell me the answer, I mean. Mean birth weight of an Indian baby. 2.5, 2.8, 3.1, 3.5. Indian babies. Indian babies we talk about. So what is the mean birth weight of Indian babies on an average? You people take too much time to answer. Yes, Leah, you are right. Absolutely right. Many people are right. Okay. So correct answer here is 2.8 kg. So the mean birth weight of Indian babies is 2.8 kg. And in the same question, if I change the question LBW, LBW is less than what? So in that case, your answer will become 2.5 kg. Okay. So you got it. If the birth weight is 3 kg, by the end of 1 year, it should be what? By the end of 1 year, it should be what? So by the end of 1 year, it triples, it triplicates, है ना? So 3 kg will become 9 kg in 1 year. Okay, so this is regarding the birth weight. I have not put this, no? Just learn it. In 1 year, birth weight triples 3 times. So whatever is the birth weight, it will become 3 times at first birthday. First birthday, it should be 3 times on an average. So it's 9 kg. Okay, coming on the height. Will you call height or length? What is good to say? Height बोलूं कि length बोलूं? क्या सही है बोलना? Length इसको कहते हैं, height इसको कहते हैं. Up to 2 years, it's length. And after 2 years, it's height. Because after 2 years, the baby stand. Before 2 years, the baby lie down. So this is the baby lying down and we are measuring. Here the baby is standing and we are measuring. So this is length and this is height. How many of you got it? Length and height, the concept of length and height I told you. Everything have a reason behind that. The instrument is known as infantometer. Can you see? It's a scale. It's a scale, calibrated scale. It is having 2 slab. Number 1 slab, number 2 slab. So 2 people are required. For measuring the length or height, 2 people are required. Height ke liye nahi, length ke liye. है ना? 2 people. So you have to lie the baby on the scale in pantometer. Keep the knees straight. It should not be flexed like that. No, keep this. So one hand should always be kept on the knees so that it should be straight. है ना? One slab should be at the head and other slab should be at the feet. है ना? Touching each other, cut to cut. So this is the height. है ना? This is the 0 and here you can measure how long the baby is. So that is the length. So it should be measured within first 3 days भी चलेगा. The weight should be measured within first hour क्योंकि उसके बाद change होता जाएगा. Length will not change much. The name of the instrument is infantometer. 2 people are required. It's a sliding board with 2 slabs. I told you. है ना? So this is the thing. Average birth height is 50 centimeter. Birth weight कितना बताया? 2.8 kg. Indian babies. And here average height is 50 centimeter. At the birth they are 50 centimeter. है ना? The height gain in the first year is around 25. So at first birthday they become 75. है ना? So at first birthday they become 75. It's double by 4.5 years and triple by 12 years. 12 years का baby हो जाएगा तो जाके 50 का 150 होगा. Got my point? है ना? Weight I am saying it's 3 kg or 2.8 kg. At first birthday it become 9 kg. First birthday. Height I am saying 50 centimeter. At first birthday it's only 75 centimeter. It's not even doubling. Tripling तो दूर की बात है. So weight triples on first birthday. Height only increases by 25 centimeter. Got it? So these things you have to learn. Okay. So the same thing of the height charting. First year, every year 25 centimeter. Second year 12 centimeter. Third year 9 centimeter. Fourth year 7 centimeter. Fifth year 6 centimeter. इतना बढ़ेगा. है ना? So birth is 50. So 50 plus 25, it will be 75. 75 plus 12, 87. 87 plus 9, whatever is the calculation. I'm not interested. है ना? So please, this is how height increases very gradually, but weight increases very fast. I hope you got it. Okay. So this is the thing. Read the question. So height of a newborn doubles at what age? Doubling कब होता है? First birthday पे तो नहीं होता है. First birthday पे 50 का 100 नहीं होता है. At 4.5 years it doubles. I told you. है ना? Here I told you at 4.5 years. ना? It is doubling at 4.5 years and tripling at 12 years. So answer is 4 years. 4.5 is the actual answer. है ना? So 50 का 100 becomes at 4.5 years. Got it? है ना? So let me tell you a very important concept, malnutrition. You get always a question on malnutrition and very few students understand it. Please understand here. I'm trying hard. Please understand. Give me a minute. So let me tell you what is acute malnutrition. Let me tell you what is chronic malnutrition. And let me tell you what is acute on chronic malnutrition. Let me tell you the 3 terms one by one. Okay. Let me see. So imagine, let me explain the terms meaning to you. Acute malnutrition, chronic malnutrition, acute on chronic malnutrition. Matlab kya hai? What do you mean by that? Imagine a baby is there. The baby was belonging to a good family. The baby was feeding. The weight was normal. Suddenly, baby become ill, very sick. Or baby got kidnapped. है ना? Or the mother of the baby is dead. Or suddenly there is a tragedy in the family. So the feeding of the baby stops suddenly. है ना? Either the baby is ill, sick, the baby is kidnapped, है ना? The baby is lost, and some tragedy is there, anything. So suddenly, the word to be picked here, I want to hear, due to any circumstance, it's sudden. Till now, it was normal, but suddenly the food is stopped. So baby will have acute malnutrition. What the baby will have? Acute malnutrition. है ना? This is known as acute. Chronic means the baby is poor. Belong to a very poor family. They are beggars. They don't have money to eat. Or to some family, they don't bother about the feeding of the child. They don't have parents like that. They are in an orphanage. So such babies here, it is gradual. It's not sudden. It's gradual and always. And it's known as chronic malnutrition. Such babies will have chronic. Imagine a baby who is chronically malnutrited. The baby is chronically, and on that acute on chronic, the baby becomes sick also. A chronically malnutrited baby becomes sick. So it is acute on chronic. And it's Sone pe suhaga. Got my point? Now listen. Imagine you have three things: weight, height, and age. Weight of the baby, height of the baby, age of the baby. Listen. If you suddenly stop feeding, what will be affected? Weight or height? What will reduce first? Common sense. Weight come hoga ki height come hoga? If today I'm not eating, for many days I will not eat. For the next 10 days, I'm not eating anything. So my weight will reduce first or my height will reduce. I'm not a kid, but for a kid, we are talking. We are talking for child. Common sense, no? First weight will fall. First weight, obviously. Yes. So acutely weight is affected. So say weight upon height. We measure acute malnutrition by reduced weight for that height. For that particular height, whatever weight should be there, it is less than that. That is known as reduced weight by height. This is the formula for acute malnutrition. No need to learn, common sense. Acute hai matlab sudden. Suddenly you stop feeding. So weight is affected. So weight will fall as compared to height. Height is still normal. Okay, but chronically, if you don't feed a baby now, the height will be less as compared to normal. The baby will start short. As compared, they are not tall. Their height will not increase. So their height for age is less. For their age, whatever should be height, it is less than that, chronically. Hana, acute on chronic, divide the two, acute upon chronic. So say acute upon chronic. So what is the formula of acute? Weight upon height. Say weight upon height. Whole upon. What is the formula of chronic? Height upon age. So say height upon age. Height cancel. Weight upon age. So here the formula is weight upon age. I don't learn these. I can understand. So read the three formulas. Here the formula is weight. Read the formula. Yes. Acute malnutrition, here weight for height. And this one is height for age. Divide the two. Height cancel. It's weight for age. Weight for age is acute on chronic. How many of you got it? One more thing I would like to tell. Acute malnutrition, also known as emaciation. Chronic malnutrition, also known as dwarfing. Dwarfing means short. And acute on chronic is underweight. Say something. Respond, people, respond. Say something. Acute malnutrition, chronic malnutrition, acute on chronic malnutrition. Tell me their other names, please. Acute malnutrition, also known as emaciation. Chronic, also known as dwarfing. And this one also known as underweight. Okay? Say acute matlab sudden. So suddenly weight is affected. Weight for height. Less weight for height. Chronically height is affected. So less height for age. Divide the two. Height cancel. It's weight for age. So less weight for age. This is how we learn. If you understood, it's good. If you didn't understood, learn the three formula. Acute malnutrition, chronic malnutrition, acute and chronic. Every year you get question on that and you get confused. Read the question, tell me the answer. So deficit in weight for height. Weight for height. In a 3-year-old kid. What does it indicate? There is less weight for height. Is it acute malnourished, chronically malnourished, concomitant acute and chronic, or underweight? What do you say? Weight for height. The weight is less as compared to height. So yes, it's a formula of acute. Shivangi, not chronic. It's a formula for acute. For chronic, I told you height for age. I'm saying weight for height. So correct answer here is A, not B. Correct answer here is A. Got it? And if I change the question, weight for height ki jagah, height for age kar दूं, then answer will become chronic. Or you got it, weight for age kar दूं. Weight for age. So answer will become acute on chronic. That is underweight in that case. So that is the thing. What is the best parameter to assess the chronic malnutrition? For chronic, you tell me. What is correct for chronic? Weight for age, weight for height for age, or any of the above. Chronic के लिए क्या affect होता है? Chronic के लिए height is affected. So height for age is the correct answer, I guess. So it's dwarfing. I told you. So you get many questions on that. I hope you got it. We are done with weight. All the important points I already taught you. We are done with height. All the important points I already taught you. Weight और height को मिला के the acute, chronic and acute on chronic तीनों तरह के malnutrition I taught you. Can I move ahead? The third criteria now. We are done with weight. We are done with height. तीसरी चीज पे आते हैं head circumference. the head circumference of the baby. Can you see? We measure the head circumference with a tape. The name of the tape is, no, not a tape, simple inch tape. Have you seen an inch tape at your home? Simple inch tape we use. Hai? So we measure, where to measure? Here, here, here. What is the level? It is the level of the occiput. We all have occiput here. Here we have the occiput, you can feel. So at the level of the occiput, we do the measurement. Okay. And it should be measured during the first 3 days of life. Okay. First 3 days of life. Birth head circumference is 35. Now tell me birth weight. Tell me birth height. Tell me birth head circumference. Till now we have studied 3 things. Birth weight, Indian birth weight is 2.8 kg. Birth height is 50 centimeter and head circumference is 35 centimeter. Please learn, it's 35 centimeter. Now it keep on increasing. At 3 months, it become 40. At 6 months, it become 43. At 1 year, it become 46. At 2 years, it become 48. And at 12 years, it become 52. And after this, it is always constant, 52. So if you measure yours and mine, it should be 52. Plus minus thoda bahut. So 52 ke baad aur nahi badhega. It's maximum. Start from here and measure. It's 52. It will not increase now. Okay. So this become constant after that. Okay. So this is the thing. This is how it rises. At 12 years, it become constant. That is 52. So from 35 to 52, it increases like that. Read the question, tell me the answer. At birth, the head circumference is what? Just now I taught you, it is 35, but 35 is not there in the option. So we will go with 34. But best is if they give the 35. Hana? The next is the chest circumference. Here how? Again, we measure with an inch tip. You can see, we measure at the level of the nipple. So nipple of the baby. Hana? Nipple. Here the measurement was done at the level of the occiput. Here the measurement is done at the level of the nipple. The nipples of the baby. Okay. So we are measuring at the levels of the nipple, number 1. And how much it is? It is always 3 centimeter less than the head circumference. So if the head circumference is 35, it's 32. 32, Hannah. But in adult, so this is a kid. Now see the head, see the chest. You can see chest is very small, but the head is big. But as the child grow, reverse happen. See, the chest is more and head is less. You can see here head circumference and chest circumference. And here you can see the head is more, the chest is less. So at birth, the head is 35. And the chest is only 32. But gradually it will reverse. You are getting my point? Gradually it is reversed. Head is becoming small, and the chest is becoming large. Hannah. So at 9 months, both are equal. 9-month baby, you will see the head and chest both are equal. Hannah. And after that, there is reverse. Got it? After that, the chest is more and the head is less. Like in adult life. In adults also, the chest is more, the head is less. Hannah. Got it? So can we go at this is regarding the chest circumference. You get only one question, at what age they are equal. 9 months to 1 year. The chest and head are equal. Head circumference is equal to chest circumference at 9 months to 1 year. So this is a question you get. This is a question you usually get on chest circumference. The last is the mid-arm circumference. Till now we studied 4. Weight, height, head circumference, chest circumference. Last is mid-arm circumference. This is the mid-arm circumference. The mid-arm circumference is measured with the help of a tape. It is known as Shakir tape. Shakir. It is not a simple inch tape. It is having color coding. The red, yellow, green. It is known as Shakir tape. Shakir tape. It is a specialized tape. We have to measure. Kahan measure karun? Yahan. We have to measure, bhai. We have to measure. So take 2 bony processes. So this is my olecranon process, and here in the scapula bone we have acromion process. So acromion, mark it with a pen. Okay. Olecranon, mark it with a pen. Measure it and take the midpoint. That is mid-arm. That is known as mid-arm. So the midpoint of the 2. The acromion and the olecranon. Olecranon is this one. I guess you know. Hai? So acromion or olecranon ke beech mein jo point aa raha hai, the midpoint, that is known as mid-arm circumference. You have to tell the level. Hai? For the level of the head circumference, it's occiput bone. For the level of the chest circumference, it's nipple. Hai? And for the level of the mid-arm circumference, it's acromial and olecranon ka midpoint. Hai? So this is how you have to measure. Okay. During the first 5 years, it's constant. It's constant. Hai? It's constant because initially the child have fat here. As the child is born, muscles are less. And gradually the fat is decreasing, but muscle is increasing, but overall it's constant. So fat of the early infancy is replaced by the muscles later on. So up to 5 years, the mid-arm circumference is constant. And it is between 15 to 17. The normal is 15 to 17. If it is 15 to 17, it's normal. 15 to 17 is normal. So you can see normal is 15 to 17. More than 13.5 is actually normal. It's in green zone. Hannah, 12.5 to 13.5 is moderately malnourished. And less than 12.5, it's severe malnourished. How many of you got it? You can see. है ना? So you know, so learning these values is easy for us. You may say कि मैम color coding की क्या जरूरत है? Inch tape से ही नाप लो. I'm having inch tape at my home. I will measure. I will see whether it is less than 12.5, 12.5 to 13.5, or more than 13.5, and I will say whether it is severely malnourished, moderately malnourished, or non malnourished. I mean normal. So, but teaching all these to Asha, Anganwadi worker, they are not very high IQ people. I mean, they are not very educated. So learning these values, they can do the mistakes. So I will give them color coded tape. The tape is like that. I will just ask them. I will ask the Asha to measure the mid-arm circumference of all the children available here, Hana, and just tell me which children is coming in red, yellow, or green. So she has to just code the color. Coding color is easy, and I know the color coding. So you can see red, it's in 13.5. No, 12.5. The yellow is 12.5 to 13.5, and more than 13.5 is green. So less than 12.5, it will come in red zone. Severely malnourished child. See the face of the child. Severely malnourished. Anna, you can see this is yellow. Anna, here the child is coming in yellow zone. I mean, it's 12.5 to 13.5. It's moderately malnourished. And this one is a healthy child. Not malnourished, healthy. It is more than 13.5. So you can learn less than 12.5, more than 13.5, and between 12.5 to 13.5. This is the easiest way. And the name of the instrument is Shakir tape, color coded tape. For the Asha Anganwadi worker, we have make this tape. It is having color coding. It's easy to measure with the color coding. Say yes, this is how we measure. You can see the child is malnourished. It is coming in red zone. Say yes, say something, respond, people respond. So this is the mid-arm circumference. We are done. I told you 5 things: weight, height, head circumference, chest circumference, mid-arm circumference. Tell me the instrument with which we measure. Tell me the birth values. Instrument, here we take Salter scale. है ना? Here we take infantometer. ठीक है? Infantometer, imagine the 2 people are required with 2 slab and the knees should be straight. Head circumference is measured with simple tape, inch tape. Here also the simple tape. And here we have Shakir tape. Okay, tell me the values. The birth weight is 2.8 kg. Hana? So that is the thing. Height is 50 centimeter. Head circumference is 35 centimeter. Chest circumference is 32 centimeter. At 9 months, they become equal. 9 months to 1 year. And Shakir tape, normally it should be more than 13.5. And you know all the values, all the important things. Apart from that, I already taught you. I've shown you the images also. Can I proceed? The next is the growth chart. Can I start the growth chart? Are you people available there? Can I start the growth chart? The growth chart is discovered by David Morley. Please, it's a PYQ. Who discovered growth chart? They are like this. These are the charts. Let me tell you what is a growth chart. These are modified by WHO. These are the WHO growth chart. They will give you a visible display of the child growth. You can see a visible display. And it will give you a longitudinal follow-up every time you will do the monitoring. It is based on weight and height. Not height, I'm sorry, weight and age. Hana? So you can see on one axis, we can take the age of the child. On other axis, we can take the weight of the child. So as the age keep on increasing, I'm sorry. Just a second, give me a minute now. Let me silent it. Now, so as the age keep on increasing, the weight keep on increasing. Hana? So here, just suppose the child is coming to you at 1 month. So at 1 month, what is the weight? You just mark a point here. At 2 months, again, the child is coming for the visit. So here, what is the weight? Mark it. Hana? At 3 months, again, the child is coming. So every month, the parents are carrying the child to you. Every 6 months, they are carrying. So whenever for vaccination, so it should be always increasing. Whenever there is a plateau for 3 constant months, or there is a fall, it's an emergency, means there is something wrong. There is something wrong. So you can pick it very fast. You can pick it very fast. So it's a longitudinal follow-up. Every time we are plotting a point and we are connecting the points like that. So these are the growth charts. The growth charts are of 2 types. Now the physical development in girl child and boy child is little bit different. Physiologically, the girls grow faster. है ना? हिंदी में भी कहते हैं लड़कियां बड़ी हो जाती हैं जल्दी. Parents कहते हैं ना लड़की बड़ी जल्दी हो जाती है. तो वो सच में भी बड़ी जल्दी हो जाती है. So growth is faster in girls, and in boys it is little bit slower. It is physiological. है ना? You can see the pink card for the girls and blue card for the boys. So the color coding is done. So you can see the pink for the girl. A girl is drawn here. And there is a blue card for the boys. The boys is drawn here. So keeping in mind their physiological growth, we do the color coding here also. You can see the color coding, the green, the yellow, the red. Green, yellow, red. So just the cards are made at the time of the birth only. So here at birth, I will mark, this is birth and is 0. At birth, I will mark the weight of my child here. Now every time I will keep on marking the point here, like, like this, like this, like this. Every time the child should be in green zone. If the child is in green zone, now the growth is normal. If it is coming from green to yellow and going in red, it's an emergency. So child is malnourished. So here we have done the color coding like that. So every time, like I will, this time my birth weight of my child is this. Then next time it increases, 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 increases. So every time it's like this. So my child is always in green zone. So I'm satisfied that, yeah, my child growth is normal. But anytime it was green, 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 but now it is going play 2. Just suppose it is going in play 2. Somewhere it is going in play 2. I cannot rub it. And now you can see it is going in play 2. And gradually after the play 2, it is moving in the yellow and in the red. So you can see there is malnourishment. It can be acute, it can be chronic, it can be acute and chronic. So we have to see the reason and if we have to rectify it. Got it? So this is the best display of the child growth. Whether the growth is normal or not normal, you just make a point and connect it with the previous point. You will come to know whether the growth is normal or not normal. It is as easy as that. This is known as growth chart. So what are the two axes? On this axis, we take the age. And on this axis, we take the weight. Because weight is the best indicator. We have weight and height charts also, but weight and age are the best one. Say yes. Who have created the charts? David Morley. Who has modified it? WHO. What does it represent? A visual display of the child growth. And it is a longitudinal follow-up. We are doing the growth monitoring with the help of weight and age. Weight is usually taken on x-axis and age, age is taken on the x-axis and weight is taken on the y-axis. So we can do so. It is a visible display of the child growth discovered by David Morley. I already told you. It is the cheapest and non-expensive way of doing the monitoring. The mother can do itself on home also. Like if she's educated, she can measure the weight of a baby if weighing machine is there, and she can mark a point and she can join with the previous. If the mother is not educated, the doctor, the pediatrician can do so. So it's very easy to do. It's not a rocket science. Anyone can do so. Okay. So it's weight for height. Weight for height, we are taking the consideration. Got it? WHO home-based growth chart. Why? The home-based. We will give home-based. So this is known as road for health. This is road for health. We have make a road here. This is the normal development. This is the normal development. So every time the child should be in this road. If the child is not below this road, the child is underweight. And if the child is above this road, the child is overweight. Sometimes the childs are obese. It's not good. Obesity is also not good. This is known as road to health. What it is known as? Road to health. So it is giving a zone which we call road to health. Say yes. Got it? In this zone, 95% of the normal healthy children are coming in this zone. Okay, got it? Okay, can we go ahead? So flattening or falling is indicating the red signal. Anyone? Can we go ahead? So WHO growth chart is based on National Center of Health Statistics USA standards. WHO वाले USA के हैं. So इसलिए India में हमने अपने बनाए because every country have a different growth ना. So WHO is based on USA standards. हमने वहां से standards लेके उनके लिए road to growth बनाया है. For USA standards, the WHO is for all the countries. It's for the globe. So for India, we have make another chart. By the government of India, we have recommended another chart. This is the Indian chart. This is not WHO. So here 4 lines are there. You can see line number 1, line number 2, line number 3, line number 4. 4 lines are there. So 4 lines, the first line represent the 80% of the median. Second is 70%, 60%, 50%. So if any child is between the first and second line, it's the first degree of malnutrition. Second and third line is second degree of malnutrition. Second and third and fourth line, and below fourth line like that. It's the degree of malnutrition. Always the child should be above that. If the child is coming here, it will represent the degree of malnutrition. This is first degree, second degree, third degree, and fourth degree severe malnutrition. Here in this diagram, you can see the child is in the first degree of malnutrition. The child should be above all that. Above, not malnourished. You got my point? I'm sorry. Just a second. Give me a minute. So this is the Indian chart. You got it? So we have seen the WHO chart also, in which road to health is there, but that is dependent on the US standards. So these are the Indian charts. So these are the growth chart recommended by Government of India. Government of India, there are 4 reference curves. You can see the 4 reference curves are there. So here we will say that a grade of the malnutrition, first degree, second degree, third degree, or fourth degree. That is the interpretation. We are done. Okay, we are done. Okay, so read the question. Road to health card or growth chart was designed by which scientist? Is it Edwin Chadwick, David Morley, Gopalan, or Winslow? Name the scientist who had discovered the growth chart. What is the correct answer? Fast? Yes. So it's David Morley. Very commonly asked question. Right. Very commonly asked question. Okay. Let me see what's their school health service. Can we take a small coffee break if you people allow? Can we take a small coffee break? 15 minutes? Still, it will take 30-40 minutes. So I will finish this chapter after coffee break. Hana? So currently it's 5:12. So 5:30 is good. Okay, let's meet at 5:30 and continue it for maybe another 40 minutes. I will finish this chapter, but I'm afraid that I will not be able to start demography. I will start it in the morning only, the demography. So tomorrow demography is a big chapter and all the small chapters we will complete. Hana? So in the first from 9:30 to 12:30 we will finish demography and family planning and contraceptive, and after that small chapters. There are many small, so all of them are half hour 20 minutes like that. So small chapters we will cover all. And the day after tomorrow, it's National Health Program, communicable, non-communicable biostatistics. That's it. Hana? So we will see. Okay, Ji. So I'm not ending it. I guess it's already 3 years. We have started. So let's continue. If any trouble will occur, then we will expire. If the link expire, if any trouble, technical trouble we will face. These people say me that after every 3 years, we should change the link. But it's already 3 years have passed. Let's continue with the same link. Hana, if any trouble occur, we will change it. We will call the technical team. Okay. So I'm not changing the link. The same link we will continue. Okay. Hello, people. Are you people there? Can we continue? Is everything good to go? Can we continue? Please respond. Hello. Am I clearly visible, audible? Thank you. Thank you, Shivangi, for responding. Thank you so much. Thank you, Aditi. Thank you. So let's continue. Okay. So, okay, I was teaching you preventive obstetric pediatrics. Okay, so let's continue now the school health services. We have seen the 5 things in the child: the height, the weight, the head circumference, the chest circumference, and what is the 5th one? The mid-arm circumference. We have seen all of that. Now let's start the school health services. Okay, in the school health services, what we are providing? In the school health services, in the school age, most common defect is the dental defect. Most of the children have caries because they eat sweets, they don't brush properly, they don't do brush before sleeping in the night. So caries are very common, dental defects, most common, followed by goiter, followed by malnutrition. So these three are the most common defects found in school children. Most common is dental caries, please learn that. So medical examination should be done in all government school by the doctors every 6 months. It's free of cost. It is under national health mission. No, it's free of cost. Okay, so school children, eye screening should also be done. Can you see this? Eye screening is done. So eye screening should be done from class 5th to 8th, or 10 to 14 years of age, one and the same thing. The children who are 10 to 14 years of age, they are in class 5th to 8th. Teacher will perform. You train the teacher. Teacher will perform. One teacher for every 150 student, and the teacher will send the child to the PHC if the visual acuity of any child is less than 6.6/9. So the cutoff is 6/9. Any child who is having visual acuity less than 6/9 is referred to the PHC by the school teacher. You have to train the school teacher, and you have to provide the charts, and you have to train it how to perform the screening of the eye testing, how it is done. Okay, so this is clear. Now IAP, International Academy of Pediatrics, recommend that school children should not carry the school bag, the weight of which is more than 10% of their body weight. So just suppose the body weight of the child is let's say 20 kg, so 10% of the 20 kg. What is the 10% of 20 kg? 10% of whatever it is, so I guess it is 2 kg. Okay, so the weight of the bag should not be more than 10% of their body weight. It should not be there. It's a guideline. Okay, now if you want to make a school building, there are certain criteria. The school building, it should be 5 acres for the primary school, 10 acre for higher elementary, and additional 1 acre for every 100 students. So this is the criteria for the size of the land. The wall should be 10-inch thick, so that heat do not come inside, the cold, the temperature do not affect inside the school classes. Okay, all the walls should be 10-inch thick. Okay, the classroom, each classroom should be 40 students at a time. 40 students at a time. Per capita space should be more than 10 square feet to one child per capita space. The desk should be of minus type. You know what is minus? There are 3 type of desk available. So you see in your coaching, in your school, which type of desk are there? This is minus type of desk, in which you can see, let me explain the meaning of the minus type. Can you see? This is the table. Now table is overlapping the chair, a little bit overlap. This is minus type. Zero type means it is just touching. And in positive type, there is a big distance between the table and the chair. Which you will prefer? So this one is preferred. So you will sit here. I mean, the child will sit like this. The child will sit like this, and it should overlap. The table should overlap the chair. So chair and table, there is a little bit overlap. Not much. You can see hardly any. A little bit of overlap is there. This is minus type. So minus type is preferred. Please learn, it's a PYQ. There is a vertical line drawn from the edge of the desk to the seat, and there should be overlapping. Zero mate is just touching, and plus me, there is a big distance here between the two. So this is the 3 type of the desk. We prefer minus type here. How many windows should be there in the school? Windows and doors. So total windows and doors area should be more than 25% of the floor area. So these all our guidelines should be followed while constituting a school. Okay, the height of the windows should be high. It is not the thing that students are jumping out of the window and they are falling down. So it should be at least 2 to 6 inch high. Okay, and the wall color should be light. It should be white color or cream color, some light color. Dark color is not preferred. And light should come from the left side. Always the light should come from the left side. So most of the people are right handy. Most of the students and children, they are right handy. So shadow will not fall. Now, if I'm writing with this hand, if you give the light from this hand, my hand shadow will be there on the copy. So if the light should come from this hand, this is the reason. So most of the people are right-handed. For left-handed, there will be a problem, but maximum 90% or 99% of the crowd is right-handed. So light should fall from the left side in the classroom of the children. Okay. One urinal per 60 student and one latrine over 100 student. These are the guidelines. And ventilators, more than 2% of the floor area, there should be ventilators. So these all are guidelines for the school. Just have a look. Don't try to mug it up. These all are the guidelines for a school. So read the question and tell me the answer. This is school health. Okay. The commonest morbidity in the school is, can you please tell me the answer, please? What is the commonest morbidity in the school? Dental caries, worms, malnutrition, or skin diseases. I guess you all are right. The correct answer is the dental. Dental followed by goiter, followed by malnutrition. If dental is not there in the option, I will go with malnutrition. But currently, the correct answer is the dental caries. All of the following are the minimum standard for sanitation in a school and its environment in India, except. So desks are of minus type. Is it true or false? Door plus window should be minimum 25% of the floor area. Is it true or false? One classroom, 40 student. Is it true or false? Every 10 student, there is a urinal. And every 25, there is a latrine. Is it true or false? I guess D is false. Urinal should be over 60 and latrine should be over 100. Every 100, one toilet, I mean. So you have to learn the guidelines. So this one is false, I guess. You get simple question. Reading the question, you can make it out. Don't try to mug it up. Don't try enumerating all the guidelines. No, read it, understand it, leave it. And in the option, you can make it out. Okay, this is a way. So coming on the last thing here is the MCH indicator. What is MCH indicator? Maternal child health indicators. We have done with preventive obstetrics. We have seen antenatal, intranatal, postnatal care. We have done with preventive pediatrics also. I have told you infancy also, newborn also, the 5 things, the weight, the height, the head circumference, chest circumference, mid-arm circumference. I've told you breastfeeding also, the milk also, everything of that. And LBW also, kangaroo technique also, we have done. School health also. So infancy and children is also done. Let's combine the two. Maternal child health. Why there is a separate wing, MCH wing? Because whenever you call mother for the health checkup, they will not leave their child. They will carry their child with them up to 5 years. Child are not alone. They usually carry their child with them whenever they are coming for their own checkup also. And whenever we call the child will not come alone. Child obviously will come with the mother usually. So let's combine the two wing. The maternal child health. Both are very fragile groups. So let's combine and make one wing. There is a wing known as MCH wing. This is the reason. Because let's take the advantage of this opportunity. Mothers don't come alone. They come with child. Child will not come alone. They come with mother. If both of them are coming to you, let's examine both. Let's examine both. So this is known as MCH, maternal child health indicators. Can I start? Let me tell you maternal indicators, then I will tell you infancy and child indicators. In the maternal, we have only 2 indicators. Maternal mortality rate and ratio. In the morning, I told you the difference between the rate and ratio. Those students who are attending the session from the morning, they know that. I told you the difference between rate, ratio, proportion. So I told you here also we have numerator and denominator. And here also we have numerator and denominator. But in ratio, they are 2 different entities. They are not related to each other. But in rate, the numerator is a part of denominator. Let me tell you the formula of maternal mortality rate and ratio both. Let me write the formula for you. Okay. Let me write maternal mortality rate and let me write maternal mortality ratio. Please, you understand. You yourself decide, is it a rate and ratio, yes or no. So there is a numerator and denominator in both of them. Okay, ji? Let me tell you. In rate, the denominator is all reproductive age female. Reproductive age female, that is 15 to 45 or 15 to 50. Menarche to menopause. Usually menarche occurs at 15, menopause occurs at 45 to 50. So these 35 years of fertility, the female can be fertile and reproduce in this age group. Before 15, she can't reproduce, and after 50, she can't reproduce. After menopause, she can't reproduce. So this is the thing. Okay. So this is the denominator. The numerator is out of these female, how many are dying? They are dying. The death occur either during pregnancy, at the time of the delivery, or after pregnancy within 42 days of postpartum. This is considered as maternal death. So during pregnancy, entire gestational age, 9 months, 9 days. Or at the time of the delivery, some female is dying. Or within 42 days after the delivery. Now this within 42 days as a complication of delivery or as a complication of pregnancy. Now within 42 days, if the female is doing suicide, we are not considering it as at MMR. Suicide is not related here. But due to some bleeding, some complication, some infection, something is happening as a complication of delivery, she is dying within 42 days after delivery. So all those deaths we will consider here. So the females who are dying are reproductive age females only. They become pregnant. So the numerator is a part of denominator. Of course, they are not aliens. They are part of denominator only. So it is a rate. I will say it is a rate. And the multiplier here is usually 1 lakh we take. In the rate I told you, it's never 100. It can be 1,000, 10,000, 1 lakh. Usually we take 1 lakh. Okay, coming on the ratio. In the ratio, the numerator is same. All the females who are dying during pregnancy or at the time of the delivery or within 42 days after delivery. But denominator is not reproductive age female. Denominator is live birth. All the live birth. Numerator is different, denominator is different. Numerator and denominator are not part of each other. So I will say it's a ratio. How many of you got it? Please understand the denominator is different. You can see the numerator is same in both of them. How many of you got it? I want you to concentrate on the denominator. Numerator is same in both of them. Here you can see numerator is a part of denominator, but here numerator and denominator are different entities. Respond, people, respond. This is the difference between maternal mortality rate and ratio. Now you will not forget. You know the difference between rate and ratio. Hana? So this is the maternal mortality rate and ratio. The reason for both of them is the bleeding. It can be antenatal, intranatal, or postnatal. Hana? So hemorrhage is the most common cause. Hemorrhage, bleeding. Vaginal bleeding. It can be during pregnancy, at the time of the delivery, or after delivery. The most common cause of the death. Maternal mortality rate and ratio both. So that is the maternal mortality. So let's start maternal mortality ratio. See the formula directly. I already told you the formula. See the denominator, it's live birth. And see the numerator, number of female who are dying either during pregnancy or at the time of delivery or within 42 days after delivery as a complication of delivery. So that is the numerator. Numerator, denominator are different entities. So that's why it's a ratio. That's why it's a ratio. The most common cause is hemorrhage. I already told you. The second most common cause is abortions. Okay. Maternal mortality rate. See the formula. See the denominator. The reproductive age female, 15 to 50. All the females. From them, some will become pregnant. So during pregnancy, if someone is dying at the time of pregnancy or at the time of delivery or within 42 days of delivery, the multiplier is 1,000, 1 lakh. We can take anything, but never 100. It's not in percentage. So this is the thing. We have learned two things till now: maternal mortality ratio and maternal mortality rate. See the numerator, see the denominator, see the numerator, see the denominator. I want to highlight the numerator is same. Number of maternal death. You know what is a maternal death? Any mother who is dying antenatal, intranatal, postnatal. That is a maternal death. Postnatal is up to 42 days. But denominator is different. Here denominator is live birth. Here denominator is reproductive age female. I guess it's crystal clear. Okay. So MMR, maternal mortality ratio, is a ratio because numerator is not a part of denominator, but in rate, the numerator is a part of denominator. Say yes. Say the answer. What is the leading cause of maternal death in India? Anemia, hemorrhage, sepsis, or obstructive labor? What is the most common cause of maternal death? Maternal mortality rate or ratio, both. Most common cause दोनों का एक ही है. What is the most common cause? Bleeding, hemorrhage per vagina, antenatal, intranatal, postnatal. Anytime. The bleeding is the most common cause. So correct answer here is B. You all are right. Maternal mortality ratio is what? See, which is the formula of maternal mortality ratio? Can you tell me the formula? See, the four options are in front of you. I'm saying ratio. See the numerator, see the denominator. What is the correct answer? Numerator is maternal death only. The denominator is live birth. Okay. All the denominator is also live birth. It's not population, it's live birth. But it's only live birth or no. It's per 1 lakh. This also we calculate 1 lakh. You will say, ma'am, ratio mein to multiplier nahi hota. But here usually we take the multiplier as 1 lakh. We take the multiplier here as 1 lakh. So we calculate it as 1 lakh. Okay. So correct answer is C, not A. Don't get confused. Not A, not B. Correct answer is C. We calculate both of them as 1 lakh. Okay. See the next question. See the next question. All of the following death are included in maternal death except which is not a maternal death. Is it following abortion, during lactation first month, during lactation 8th month, and during the last trimester due to antepartal hemorrhage? Which death is not maternal death? Can you give common sense? Can you give the answer? I'm really sorry. What is the correct answer? Yes. Absolutely right. Someone has given the correct answer. Yes. So what's the correct answer? Yes. The correct answer is C. I told you up to 42 days. 42 days is 1 month, 1.5 months. It's not 8th month after delivery. No. This will not be maternal death. I told you during pregnancy during delivery or at the time of abortion, at the time 42 days after delivery. Abortion is also included here. No? Abortion is also included. First month we will include because it is coming in 42 days. But 8th month we won't include. Last trimester is in pregnancy only. So C is the correct answer. I guess you all are right. So you get simple questions on that. If you have an idea, you can make it out. So we are done with these two. The last thing I'm telling you here is this. I know. So I'm telling you the mortality during infancy and childhood. Let me tell you, Hannah, to understand the perinatal mortality rate, neonatal mortality rate, post-neonatal mortality rate, Hannah, infant mortality rate, 1 to 4 year mortality, under 5 mortality, child survival rate. So let me explain all these terms to you with the help of a diagram. Understand this diagram first. Everyone understand this diagram. Please have a look. Rather, I would like to draw this diagram for you. Let me draw an axis. This is the birth of a child. This is the birth of a newborn. Let me write B, B for birth. Hannah, this is B, B for birth. Okay, from birth till 28 days. This is 28 days. I'm not saying 1 month. 1 month and 28 days are different. 28 days matlab 4 week. Hannah, I'm saying 4 week. 4 week and 28 days, one and the same thing. I'm not saying 30 days. Please mind it, 28 days. And I'm saying this is the first birthday of the child, 1 year. Okay, so I will call this period as neonatal. This is neonatal period from birth till 28 days. And from 28 days till 1 year, I will call this period as post-neonatal. How many of you have trouble? I guess you all got it. It's very easy. Post-neonatal. So if I say what is neonatal, you will say 0 to 28. 28 days. Not weeks, 28 days. I mean 4 weeks. And what is post-neonatal? From 28 weeks onwards till first birthday, first year. This is known as neonatal. Got it? Now let me say, I will say neonatal period is very crucial. If the child is sick, child will not survive the neonatal period and child will die in the neonatal period. If some child is surviving neonatal, there are high chances कि वो ऊपर भी जाएगा, आगे भी जाएगा. So first 30 days are very crucial in the life of a newborn, especially the low birth weight newborn. Whether they will survive ahead or they will die, it depends on the first 28 days. If they can withstand first 28 days, now the risk is very less and they will survive ahead. In the first 28 days, the first 7 days are ultra crucial, very high, very crucial. Child will survive or not survive depends on the first 7 days. So let's divide the neonatal period into two portions. So 0 to 7 is early neonatal, and from 7 to 28 say late neonatal. This is neonatal, the two type of neonatal. I guess everyone can understand, not a big deal. So first understand neonatal and post-neonatal. And neonatal is further divided into two, early and late. Neonatal is itself crucial, but in that the ultra crucial is the first 7 days. So let's say early neonatal, that is ultra crucial. What is early neonatal? 0 to 7. And what is late neonatal? 8 to 28. Day 8 to day 28. Am I crystal clear? What is post neonatal? Day 29 onwards till 1 year. Give me a thumbs up, people. Got it? And let's add all of them. So starting from birth till first year, till first year, it is known as infant. It is known as infancy. So let's say this is in infancy. So can I say what is infancy? Infancy is the summation of early neonatal, late neonatal, and post neonatal. If you add all of them, you will get infancy. Infancy is 0 to 1 year. 0 to 1 year, complete. So that is infancy or infant. Okay, no trouble till now. Okay. So let's go before birth in the gestation. I have extended the line. Now I want to draw something before birth also. Let's take 28 week of gestation. This is not 28 days. Don't get confused. This is 28 days after birth. This is 28 week of gestation. 28 week of gestation. So I consider 28 week of gestation, we consider life here. So this period is known as late fetal. What is this period known as? From 28 week of gestation till birth. Intrauterine. This is not born. The fetus is inside the uterus of the mother. This is known as late fetal. Say yes. This is known as late fetal. Now let me tell you various types of mortality. Can I start, people? Are you people with me? Listen, if any death occur in this period, it is known as stillbirth. Stillbirth. Late fetal death is stillbirth. That is any death occurring intrauterine only. Inside the uterus of the mother, the baby dies. From 28th week onwards before birth. This is known as stillbirth. Very easy to understand. Okay, this is stillbirth. Any death occurring in this period, early neonatal, it is early neonatal mortality rate. ENMR. Any death occurring in late neonatal period from 8 days to 28 days. This is known as late neonatal mortality rate. And the summation of the both is neonatal mortality rate. है ना? Any death occurring from birth till 28 days. That is neonatal mortality. उसमें भी first 7 days is early and later on from day 8 onwards till 28 days it's late. है ना? Any death occurring from day 28 till 1 year. This is known as post neonatal mortality rate. PNMR. And any death occurring from birth till 1 year, it's known as infant mortality rate. I'm highlighting everything. Please see. Have a look. You know what is stillbirth? Say yes or no. You know what is NMR? Neonatal mortality, post-neonatal mortality, and the summation of the two is infant mortality. Neonatal mortality is of two types. The neonatal mortality is of two types, early neonatal, late neonatal. You can say the definition of all of them. The death is occurring in which age group? Say, respond. Got it? Got it? Anna? So these are the terms you have to learn. What is stillbirth? Anna? What is stillbirth? Any death occurring from 28th week of gestation till birth. That is stillbirth. What is neonatal? Any death occurring from day 0 till 28. That is of two type, early and late. है ना? What is post-neonatal? Day 29 till 1 year. What is infant mortality rate? Any death occurring from birth till 1 year. Okay, now the last term I am telling you here, that is perinatal. Peri का मतलब क्या होता है? What is peri? थोड़ा पहले थोड़ा बाद में. Natal मतलब birth. Birth से थोड़ा पहले ले लो थोड़ा बाद में. This is birth. Let's say this is birth. इससे थोड़ा सा पहले और थोड़ा सा बाद में. A little bit before, a little bit after. That is the meaning of the peri. है ना? So a little bit before I will include the stillbirth. All the stillbirth. And a little bit after I will include the early neonatal. So any death occurring in this period, that is perinatal. Perinatal is little bit before, little bit after. Not a big deal, you can say. Say it. What is perinatal? Any death occurring from 28th week till birth and from birth till first 7 days. That is known as perinatal. This is perinatal mortality rate. Everyone got it? Shall I remove this diagram? Once it will be gone, it will not come again. Shall I remove it? See this diagram, the same diagram shown to you. You can see the same information given to you. You can see this is 28th week of gestation. This is birth. This is 7 days. This is 28 days. This is 1 year. And you can see this is late fetal death. This is early neonatal. This is late neonatal. This is post neonatal. This is total neonatal. This is infant. And this is perinatal. A little bit before birth, little bit after birth. Everything is shown to you. Everything. The denominator of all of them is live birth. And the multiplier of all of them is 1000. They all are rate. They all are rate. Got it? So shall I say the formula of all of them? Till here I told you. What is perinatal? What is neonatal? What is post-neonatal? What is infant? Neonatal, again, I told you of two types. Early neonatal and late neonatal. I told you of two types. So you can say the formula of all of them. Can you see the formula? Or shall I write? Shall I write? Shall I write the formula of stillbirth? Shall I write the formula of perinatal? Perinatal mortality rate? Shall I write the formula of neonatal mortality rate? Shall I write the formula of post-neonatal mortality rate? Shall I write the formula of infant mortality rate? I will write. Once for all, I will write. Okay. So here you have to tell me the numerator and denominator in all of them. So denominator is live birth. Say live birth in all of them. It's very easy. Numerator is the number of death. Number of death where? Number of death from 28th week till birth. Number of death from 28th week till birth and from birth till 7 days. थोड़ा पहले थोड़ा बाद में, a little bit before, a little bit after. Birth से थोड़ा पहले थोड़ा बाद में. Neonatal, number of death from birth to 28 days. This is of two types. Early and late. In the early, it's from birth to 7 days, and here 8 days to 28 days. Better to say like this. In post-neonatal, from 28 days till 1 year, any death. And from IMR, it's birth till 1 year. I guess multiplier you can add everywhere 1000, 1000, 1000, 1000, 1000. We are done. No need to learn. Very easy. Very easy. So these are the formulas we have seen. We have seen perinatal, neonatal, post-neonatal, infant mortality, the two types here we have seen. Now, what is pending? 1 to 4, under 5, and child survival rate. I will explain this. You can understand 1 to 4. So till 1 year we have seen here. From 1 year onwards till 4 years. So I will explain you these also. So what is stillbirth? Any fetus who is dying from 28th week onwards till birth. That is stillbirth. At 28th week, what is the weight of the fetus? It's 1000 grams. So either you say 28 week or you say 1000 gram, it's one and the same thing. So you can see here definition, fetus who are whose weight is more than 1000 gram. I mean who are more than 28 week. 28 week till birth. That is known as stillbirth. Okay, denominator is live birth into 1000. Okay, perinatal mortality a little bit before birth, a little bit after birth. See the stillbirth and the number of early neonatal. The number of early neonatal. So this is perinatal. You can see it here better in the diagram. Got it? So tell me the definition of perinatal. What is perinatal mortality? Please tell me the definition. Is it death within the first week? Is it abortion, stillbirth, and death within the first week? And is it death from 28 week to first week of life? Or is it death within 1 month of life? What you will say? Don't rush. Don't rush. Take a calm breathe. Read all the options before you mark. I always say, read all the 4 options. Better to go with C. Someone is saying B also. Abortions are not there. I have not mentioned abortions. I told you all the death from 28 week onwards till first week of life. 28 week of gestation till birth and birth to first week. So this is the perinatal. A little bit before, a little bit after. If I change the perinatal to neonatal, what is your answer now? From the same 4 options, what is neonatal? What is neonatal? Try it out. What is neonatal, people? It is within 28 days. But 28 days is none of the option. I will go with 1 month. Ideally, it should be 28 days. The best is to go within first week. No, Nikita. First week is early neonatal. I'm not asking early neonatal. I'm asking neonatal. It should be up to 28 days of life. If 28 days nahi hai, to theek hai, go with 1 month. The best is to go with 1 month. If I say early neonatal, answer is A. This is how you will change your answers. So let's see them one by one. Neonatal, I already told you the formula. Death within 28 days upon live birth in 2000. This is neonatal. It's of 2 types. I already told you, early and late. Early is within first week, from birth to 7 days, and late is 8 days to 28 days. I already told you. So early is high in boys and late is high in girls. Can you tell me the reason? Can you tell me the reason? At birth, boys are very fragile as compared to girls. Girls have more stamina at birth. Later on in life, the boys become more musculature, they become more powerful and more strong in later life. But at birth, they are very fragile and girls are strong at birth. Later on, reverse occurs in adult life. Okay. So at birth, since boys are very fragile, that's why early neonatal mortality is more in boys as compared to girls. But late neonatal, after 8 days, what is happening? What is happening after 8 days? Why? Because in Indian culture, the girls are not given good care. Many mentality of many people is like that. The girl is a burden and like that. So girls are not given good care. That's why in late neonatal, the deaths of the girl child is more. So the same thing is written. Early neonatal is more in boys. Overall, neonatal is more in boys, but early is more in boys, later it is more in girls. Okay, so this is the reason. Can we go ahead? So that is the thing. That is the thing. Most common cause of early neonatal is prematurity and congenital defects. And most common cause of late neonatal death is infections, especially diarrhea and tetanus. So please learn the most common cause of early neonatal death as well as late neonatal death. On overall, if they ask you, so overall is premature, preterm. Say yes, So here I taught you early neonatal, late neonatal. For early neonatal, most common cause of the death is prematurity and congenital defects. Late neonatal, it's infections, diarrhea and tetanus. And overall, if they ask, nothing mentioned early and late. So answer is prematurity itself. How many of you got it? Can we go ahead? Okay. Post-neonatal, I already taught you. What is post-neonatal? From day 28 till 1 year. Denominator is always live birth. Multiplier is always 1000. So you can say this is post-neonatal. Okay, post-neonatal. Okay. And most common cause is infection, diarrhea, respiratory infection. Okay. So post-neonatal bhi ho gaya, infant mortality rate. It is the number of infant who are dying from birth till 1 year. The denominator is live birth. The multiplier is 1000. This is the best indicator. One of the single largest indicator because it includes the summation of all. Infant mortality rate includes neonatal and post-neonatal both. It is the single best indicator of mortality in children. It is the best indicator of socio-economic status of a community. It is the indicator of health status of a community. It is an indicator of level of living. If you remember yesterday, I taught you PQLI and HDI. You were there in the class. In the PQLI, I told you one of the component is IMR. PQLI, people believe that money is not everything. If you want to see the standard of living or quality of life in a country, in a region, you have to see the IMR of that region. So I told you three. है ना? The number one is life expectancy at 1 year. Number two, I told you the literacy rate. And third is infant mortality rate. They don't believe for this thing. Money. In HDI, money was there. I mean, income was there. है ना? So it is an indicator for level of living. It indicates the effectiveness of MCH services. Imagine there are two countries, country A and country B. In country A, there is high IMR. In country B, there is low IMR. So what you can judge from the IMR, we can see country A don't have good healthcare services. Here, the women are not given much care. Here, pediatric and obstetric care is not good. Here, healthcare services are not good. MCH services are not good. Here, quality of life is not good. Socio-economic status is not good. But this country having low IMR means females are given very importance. They are given good care, good healthcare service, good doctor. So that is an indicator of socio-economic status. IMR. Please learn IMR. So that is the IMR. So read the question, tell me the answer. Among the following, the best indicator of health in a community. Best indicator of health. Maternal mortality rate, infant mortality rate, life expectancy, or neonatal mortality rate. So best indicator of health in a community is always IMR. Always IMR. So please learn. है ना? Infant mortality rate does not include. क्या नहीं आता उसमें? Early neonatal, perinatal, post neonatal, and late neonatal. What is not included in IMR? IMR. What is not included? Yes, you people are right. What is the correct answer? IMR include early neonatal as well as late neonatal as well as post neonatal. But it does not include perinatal. Perinatal में तो stillbirth आता है. If you see the diagram, you can make it out. है ना? Correct answer is B. I guess you can make it out. So we are done till here. Coming on 1 to 4. है ना? 1 to 4 mortality is known as child death rate. So number of children who are between 1 to 4 age group and they are dying. The denominator is all the children who are 1 to 4 year of age. From them, how many are dying? So numerator is a part of denominator. The multiplier is 1000. Maximum death occur in this age group is second year. है ना? In the second year, they start crawling, they start walking, है ना? They can move here and there, they can have accidents, है ना? Before that, child cannot walk, so it is stable and safe at one place. But once the child starts walking now, it's like hell, है ना? So they run here and there everywhere, है ना? So maximum highest risk occurs in the second year of life. Okay, and most common cause is the diarrhea and respiratory infection and accidents also. In developing countries, it's infection. In developed countries, it's accident. And the under 5 mortality rate. So all the children who are dying less than 5 years of age, the denominator is live birth, the multiplier is 1000. They are very easy to learn. Okay. And what is the most common cause? It's prematurity and low birth weight in the country like India. Okay, so just move ahead. That's it. We can move ahead. Okay. So you know the formula of all of them. Please try to write. And last one, if you wish, you can see this is child survival rate. The child survival rate, CSR, it is 1000 minus under 5 mortality. That is how many are surviving up to 5 years, not dying. The one who are dying in 5 years, just subtract them from 1000. The remaining one are surviving. So this is a child survival index if you want to learn the formula. So please write down the formula of all of them. You can tell me what is the formula. Child survival index is calculated by which formula? So it's 1000 minus under 5 mortality rate upon 10. So correct answer here is C. Got it? Anna? Got it? Huh? Mainly included in child survival index. What is included in child survival index? What is the formula? 1000 minus under 5 mortality rate upon 10. So correct answer is D. Okay. So you get questions on that. So I told you what is stillbirth, what is perinatal mortality, what is neonatal, what is post-neonatal, what is infant mortality, what is 1 to 4, what is under 5, what is child survival index. We are done. You want me to repeat all or you got it? I guess you all got it. Nothing rocket science on that. If you know the age group, the denominator is same in all of them. Most of them, the denominator is same. It's live birth. Multiplier is 1000 everywhere. Say. You want me to repeat or you got it? I guess you got it. Okay. Now the child placement. Juvenile age is what? Under 18, we say the age is juvenile. Hai overall. But under the Juvenile Act, India, 1986, for boys, it's less than 16 years. For girls, it's less than 18 years. But overall, the juvenile age, we say it's less than 18 years. Hai So what is adoption? You adopt a child. What do you mean by that? Adopt means the childs are legally adopted by the couples who don't have their own children or who want to adopt any child. Hai So this confers on both the child and the adoptive parents. The responsibilities are same. Means the parents have the same responsibility for the adopted child as their real child. And the child also have the same responsibility for the parents as a real parent because they are legally adopted each other. Hai like the natural parents. So the responsibilities are on both of them, है ना? The laws varies from country to country. In India, it is Hindu Adoption and Maintenance Act 1976, under which the child is adopted. The child can be adopted legally, है ना? So you have to learn the name of the orphanage, है ना? In Hindi, you know, anathalaya, where the children who don't have parents, they are put there. So that is orphanage. The children who don't have parents, है ना? And or else who have the parents but not taken care of their parents leave them, है ना? So they are put in the orphanage, है ना? Such orphanage, these are the orphan childs, they are placed in orphanage, ठीक है? But here they do not have the intimacy of the family life, they don't have love, care, they just have food and they have the survival. But here there are high chances they will not become good human in future, because they don't have, in childhood they don't have intimacy, they don't have warmth, okay, they don't have love of the parents, like that. So chances of becoming good citizen is very less in orphanage. That's why nowadays we are trying to convert the orphanage into foster home. What is foster home? In the foster home, the parents are there, but these are the paid parents. These are known as foster parents. Who is paying them? The government. So they are paid, they are not real parents, of course. So they will give the love and affection to the child, the orphan child living there. They will give the love, security, and affection, so that they become good citizen in future. These are foster parents. These are foster home. So what is adoption? What is orphanage? What is foster home? How foster home is different from orphanage? In orphanage, child don't have parents. Here, child have foster parents, who are the paid parents. Okay. What are remand home, juvenile home, or certified school, है ना? So here remand home में the child who are in various activities, who are antisocial activities. Any child who is less than 16 years of age and doing some antisocial activities like chori, theft or something, है ना, like that. So they are kept in remand home. They are not put in jail, है ना? Here doctor is there, psychiatrist is there, and other trained personnel is there. They will take care of the delinquent child. These childs are known as delinquent childs. Very efforts are made so that they can improve the physical and mental well-being of that child and try to make them a good citizen. What are Brostal? Now, the children who are above 16 years of age but below 18 years, 16 to 18, that is the most crucial age, no? Especially boys, है ना? So they are in some antisocial activity. So they are mini jails, you can say. So they are put in Brostal. It is an institution fall in the category between juvenile and adult prison. So adult prison यानी jail, और juvenile वाला remand home है. So it is between them. So children between 16 to 18 years of age, and above 18 the prison can be there, but below 18 you cannot put anyone in prison, है ना? जेल नहीं हो सकती 18 साल से पहले, लेकिन 18 साल से पहले क्राइम किया तो, 16 साल से पहले किया तो रिमांड होम. There is no jail, doctors are there, that's it. They will try to make them a good human. But here, है ना? So it is handled because of the misbehavior. They are put in the Brostals, okay? And maximum Brostal is of 3 years, the punishment, है ना? Such children are not punished but trained. We will try to train them, we will try to reform them. So this is under State's Inspector General of the Prisons. Got it? So that is regarding the Brostals. So read the question and tell me the answer. The boys who are over 16 years of age and who are difficult to handle in a school, in a certified school, the remand home, they are sent for training and reformation for 3 years. Where? They are sent to orphanage, foster home, Brostal, or remand home. Huh? What is the correct answer? Can you please tell me the correct answer? Yes, the correct answer is the Brostal. It's the mini jail. So that is the thing. So we are done, I guess. So we are done with obstetric. We are done with pediatrics. The last is the geriatrics, the old age. The age group, geriatric is more than 60 years. The old, So we call them senior citizen, the senior citizen category, the geriatric, more than 60 years. 8% of the population is senior citizen. Most common health problem, they have visual problem. They have cataract. Motiaband, cataract, most common. And most common cause of death in this age group is cardiovascular attack. So please learn. There are five I in aging: impairment, instability, incontinence, immobility, and isolation. These are the 5 problem of aging. Isolation, they become isolated, they are alone. Usually partner is there, it's good. If partner is also dead, they are severely alone. Immobility, they can't move from here and there. Incontinence, they can pass urine and stools in the cloth only. Instability, they are not very stable while walking. And impairment is there, multiple organ impairment. So that is 5 I's we say. We are done. You can say some image based question. This is Salter scale. This is infantometer. These are IBQs. Okay. This is standiometer. This is infantometer for measuring the length. This is standometer because in standing position we are doing. This is lying down. Less than 2 years child can't stand. So less than 2 years we use this. But after 2 years, we use a standometer in which the child is standing. standometer. This is Shakir tape. You can, you can see. This is kangaroo mother. You can see. So, many image-based questions can also come. Are you satisfied? Done? We are done with this session. Give me a feedback. Can we move? Done. Okay, so tomorrow also the timing is same, 9:30, not 9, mind it. It's 9:30 sharp. We will start sharp at 9:30. I will be starting with demography. Demography is a big thing which is pending. And tomorrow's plan and the 7 or 8 small chapters like the waste management, disaster management, international health. There are many small chapters. Mental health, social health, so social science, and many other small chapters are there. We will cover all of them one by one, and that's it. Demography, and if possible, biostats also. So biostats, demography, and the small chapters we will take together. I will send you the notes also. I will send you the annotated versions also. And after that, a day after tomorrow, communicable, non-communicable, national health program. I will try to keep only these 3 the last day. That's it. And whatever is pending, I will try to cover it tomorrow. Everything is good? Okay? Yes, obviously, Mahima. We are going to finish in the next 2 days. What is the next option? Anything else? Okay? So shall we pack for today? Thank you so much for your patience. Hope to see you on time tomorrow morning, 9:30 a.m. sharp. Bye-bye. Have a nice day. I'm ending.